And away we go. Welcome. We're going to talk about the pathophysiology of skin and bones. So before we dive into this situation, this disease process, I need you to think about first, what does normal skin actually do for you? So if I could magically peel off your skin and lay it out flat, it would cover about 2 square meters and weigh as much as a bowling ball. So contrary to what anyone thinks, this is the largest organ of the body. So now when you're on Jeopardy and they say, what is the largest organ of your body? You will all say skin. So why does that matter? Because this is not just essentially sausage casing, okay? This is not just a wrapper. This is an active layered organ that decides what gets in and what gets out. This is the barrier between you and everything else. So how much water you're allowed to lose in every second, all of that is controlled by your skin. Now, you may remember from your anatomy and physiology, there are 5 layers. So we're going to start at the most superficial layer, work our way down just to give you a brief overview. And the reason I'm doing this is because when we get to the pathologies, what you need to start thinking about is which layer of the skin is failing. And that's why you're seeing whatever it is you are seeing. So picture the first layer known as the stratum corneum. This is like the bricks and mortar, right? The bricks are dead, they're flattened. These corneocytes are stuffed with keratin, and there's a mortar, which is a lipid mix, okay? And these are made up of ceramides and cholesterol and free fatty acids. That thin wall, the stratum corneum, is what keeps your water in. This blocks pathogens and chemicals and lets you rub your clothes on your arm without shedding the tissue underneath. So when this barrier fails due to things like xerosis or eczema or increased transepidermal water loss, get used to that phrase, transepidermal water loss. That's a major function of skin. How much water is getting out and what fixes it. So what you're doing for this layer, this is where you're slathering on those emollients, and because you're literally trying to put lipids back into that mortar to get it to stick and hold those bricks together. In thick skin, like say on your palms and your soles, we add a bonus layer. There's the stratum lucidium, and this is translucent, an anucleate band of compressed keratin that gives you extra abrasion resistance and grip without turning your hand into like a rigid shell. So this is the reason you can do things like deadlift and walk on the beach without bleeding to death. So just below the stratum luteum is the stratum granulosum. That's the granular layer. So here is where the keratinocytes load up with keratin and granules. There's a profiligrin here, and this becomes eventually filaggrin. Filaggrin we'll talk about when we get to the desquamating illnesses and when the skin starts peeling off the body. But hang on to filaggrin in the back of your mind just for now. This is the aggregation of keratin into tight bundles, and there are lamellar bodies that dump out lipids to seal this barrier shut. This is where we are essentially waterproof. So skin is waterproof, right? And this seal is a program that the cells die in an orderly manner, and that becomes the stratum corneum. So this waterproof layer dies off. So what's happening is we have these 5 layers, and they continue to replenish, but they push from the bottom up and out. They push from the bottom up and out, and the next layer is there on the top with that stratum corneum layer at the top layer. So when filaggrin is in deficiency, it sounds like when Mars is in Saturn or whatever. This is not a horoscope reading here, but when filaggrin is deficient, okay, you get something called atopic dermatitis. So when desmoglein 1 is cleaved here, you get this staphylococcal scalded skin syndrome, SSSS, and we'll talk about that later as well. So you don't need to hang on to all these now. We're going to go into all these conditions in this lecture, but I'm just trying to give you an overview of where we're headed. And then the next layer down is the stratum spinosum. This is the prickle cell layer. So this matters because when you do a biopsy and you look on the histology, the cell looks like spines because of these desmosomes tying them together. And so this layer is about tensile strength and immune surveillance. It houses the keratinocytes and the Langerhans cells, which are sampling antigens. So clinically, this is the layer where actinic keratosis may and many squamous cell carcinomas start. They start at this stratum spinosum layer. This is also where contact allergens are first processed and shown to the immune system. And at the base, the bottom layer is the stratum basal. This is the germinative layer. This is your stem cell zone. This is mitotically active keratinocytes renewing the epidermis. The melanocytes are handing off pigment to protect you against UV here. This is where the Merkel cells live, and they contribute to fine touch. This layer is the origin of the basal cell carcinoma and many melanomas. So you can tell just the fact that we're at the bottom layer how deep that these cancers are originating from. And this is where things like epithelialization start when you cut yourself. So under all of this dermis and subcutis is collagen and elastic fibers. And that's where the blood vessels and the lymphatics and the nerves and the adnexal structures and the fat, they drive perfusion and thermoregulation and wound healing. So when that bottom layer that brings the good stuff in and takes the bad stuff out gets compromised, you can now think about how skin fails. And so derm pathophysiology is essentially how skin fails. Now, we started this whole semester off with the inflammatory cascade and cytokines and chemokines and mediators, et cetera, et cetera, et cetera. They keep coming back in every lecture. So when someone walks in with a rash, in this case, I don't want you to start with, what cream should I use? The first question is, when you see a rash, is this immune mediated? And if so, what type of hypersensitivity am I looking for? So you can search online on your other screen right now for prototypical example images of each of these hypersensitivity reactions. So you can snap a screenshot and save that picture for yourself for reference. But what you're going to see when you look at these different types of skin reactions are the fingerprint of different immune mechanisms. So if you can link the timing and mechanism and morphology, you'll stop guessing and then you'll start recognizing patterns. So go ahead and feel free to look up some of these lesions and snap a screenshot or write a note for yourself to do it later on. Because now we're going to walk through what these different types of hypersensitivity reactions may look like. So the first one, type 1, immediate. IgE mediated. This is your right now response. Think of this as something that happens within minutes after exposure. So mast cells are loaded with IgE and they're just waiting for a trigger. That trigger could be food, drug, latex, insect sting, anything. And once that's activated, they degranulate and dump histamine and leukotrienes. So clinically, what this looks like is you're going to see this trifecta of symptoms like urticaria, angioedema, and in bad cases, maybe anaphylaxis. This is a boom situation, not a burn. This is a fast onset, fast escalation. So your question here needs to be, when you see this type of reaction, what did they just eat? What did they just take in? What new exposure have they just had? Because your treatment is going to follow that mechanism of blocking histamine and calming the mast cell and protecting the airway. The type 2 cytotoxic antibody dependent, this type 2 slows the timeline to hours to days. This is IgG or IgM antibodies targeting an antigen on the surface of the cells. This is complement gets activated and the natural killer cells join in, and normal cells become this collateral damage in the process while the body's trying to keep from dying. In the skin, this classic example would be something like pemphigus. This is like autoantibodies against the desmoglions, where you literally are breaking the Velcro between the keratinocytes. And what do you see here? Well, here, this is where you're going to see a flaccid bullae. Those are little erosions, often with mucosal involvement. And the skin architecture is being dismantled. Systematically, think of this as the drug-induced cytopenia. You have platelets or red cells being destroyed, and then they show up as purpura or petechiae on the skin. Now, this rash can be your clue that the bloodline is under immune attack. The third type of reaction here is this immune complex mediated. This type 3 stretches out from days to weeks after the exposure. What's happening here is you have this circulating antigen antibody complex formed, and instead of being cleared by the deposits in the vessel wall, complement gets activated. And what's happening is the neutrophils are starting to swarm in, and then that inflames the vasculature. So clinically, what that gives you is something that looks like leukocytoclastic vasculitis, or like palpable purpura on the skin, especially on the lower legs. A later effect of this could be something like serum sickness-like reaction. That's when the patient develops fever, rash, arthralgias after a drug infection. My daughter had this in relation to penicillin. We didn't know she was having it because it was so many days later. And of course, it's a holiday weekend and the doctor's out and they switch from penicillin to cephalosporin, and she's in the 10% that happen to be cross-sensitive, and the joints are swelled up and she's like, too acute and in pain and whining and sad. And take her to the doctor, and it's like, oh my God, this is serum sickness. You never want to be the special one at the doctor's office. When they say, can I bring in the residents, the interns, and everyone and their mother to look at this because we never get to see this? Yeah, you never want to be the interesting patient, but serum sickness is this type 3 reaction manifesting with fever, rash, arthralgia, etc. So this is like immune shrapnel. After the bomb goes off, you're having like collateral damage. And these complexes lodge in small vessels, and then later they detonate. It's like unexploded ordnances, and suddenly they just go off when you least expect it, wherever they land. The type 4 is this delayed T-cell mediated, and this is a very slow burn. And by slow, I mean 48 to 72 hours after exposure. This is a T-cell driven response. Those helper and cytotoxic T-cells orchestrate the cellular response. No antibodies are involved here. This is just cytokines and direct cell killing. An everyday example of this would be something like allergic contact dermatitis. Poison ivy, nickel in jewelry, fragrances, topical antibiotics, things like that. So the patient touches it on Monday and thinks, well, I was fine. And then Wednesday, there's like this red, itchy, blistered reaction. On the severe end of the type 4 reaction is something like a Stevens-Johnson syndrome or a toxic epidermal necrolysis syndrome. So these are often drug triggered, like with a cytotoxic storm that starts to peel away the epidermis. This is a dermatologic emergency. So here, the timing and the questions are critical. When did this drug when did you start that drug? And when did this rash appear? If there's about a 2 to 3 day delay plus systemic symptoms, that should make you think of a T-cell memory, not an IgE reflexive response, because it took time for the body to recognize. So as you look at those images you pulled up, I want you to practice this mental script. How fast did it appear? What does it look like? Does this fit a pattern of type 1, 2, 3, 4? And then once you can do that, you'll be much easier able to differentiate what is actually going on, and then the treatment will follow there. Okay, let's talk about this concept here when the immune system fails or gets old. There's a phrase here called immunosenescence, all right? And this is not just everything getting weaker or slower. What's actually happening here is things are getting distorted. This isn't pure decline. This is like imbalance in the adaptive immune system quiets down. So while the innate system is keep simmering, the adaptive one, slower to adapt. That's why it's called immunosenescence. Happens as you get older. The result in this is this chronic low-grade inflammation with lousy precision. And the fire is still burning, but it can't focus as to where it needs to go to burn up the invader. So now the problem in this situation is as you age, you have the thymus and bone marrow are basically getting old and the output of their production is dropping off. So you make fewer naive T and B cells and your repertoire starts to shrink as to the things you're going to be able to fight off. And what's left is just a bunch of memory clones replaying that old script from the past infection or the past vaccine. And so when like a novel pathogen invades you or a new vaccine shows up, the response is kind of blunted. It's slower, it's incomplete, and there's less antibody diversity. So clinically, that means your older patient can have a normal white cell count and still have a non-functional immune orchestra, essentially. It's kind of like that. It's a few beats behind. And that may not, and so what that means, of course, is these are the people that are not going to mount that classic fever response or redness or pus. They just quietly decline. They get a little more confused. They get a little weak. Now, there is a situation where at the same time in their decline, there's this paradox that goes on. So while the adaptive immunity is weakening, this baseline inflammation is going on, and cytokines like IL-6 and TNF, they sit in the background all the time. And what those cytokines are doing is they're essentially doing what's called inflamanagement. Right? They're doing inflamanaging. That's what their job is, inflamanagement, okay? They're just kind of there, non-specific, ready to fire off that protective inflammation when you need it. Well, this chronic smoldering state delays keratinocyte migration and collagen remodeling. So wounds get stuck in the inflammatory phase instead of progressing to like proliferation and remodeling. Now, at the bedside, this looks a lot like maybe a venous stasis ulcer that never closes, or the pressure injury that looks the same week after week after week. And it's not always that the nursing care is bad or they're understaffed. No, this is an underlying pathophysiology here. So in the skin itself, the immune sentinels thin out. And so there are fewer Langerhans cells to capture antigens and present them to the T cells. And so the neutrophil chemotaxis becomes sluggish. So the response to a break in the barrier is delayed. And then the common comorbidities that happen as you age, things like diabetes and vascular disease, malnutrition, and the infection risk, all of these things skyrocket. So when a geriatric patient rolls in with cellulitis, you don't just ask, what bug is this? What you're really asking is, what barrier failed first? And why was the immune response so slow? Now, this carries over into wound healing and the breakdown in that cascade. So if you put all this together, the wound healing cascade is essentially falling apart here. So you get this prolonged inflammation, which reduces the angiogenesis. You have weaker collagen cross-linking, and the outcome is this fragile granulation tissue and scars with low tensile strength. And what that means is the skin is going to tear simply with tape removal or a tiny shear injury that evolves into a chronic ulcer. So for older adults, this shifts the mindset. The priority becomes that of prevention, not heroic repair. You got to protect the barrier. You need to offload the pressure. You need to manage the nutrition and the comorbidities, because once that system is dysregulated, healing is already an uphill battle. Now, what do newborns and older adults have in common here? Well, these two live on the biological edge of vulnerability, not from disease, but from the physiology. So the skin in these two life stages tells you a story. In one, it's unfinished, and in the other, it's worn down because it's tired. So we compare them here. So the fragile beginning and the fragile end. So in the neonate, they have immature defenses and high risk for exposures. Right? So the immunity work is a work in progress. In the innate and adaptive systems, they're still being learned, right? They're still developing. So they have very few memory cells. They have a sluggish complement reaction, and they have a limited antibody repertoire because they've yet to be exposed. The stratum corneum is thin in the neonate, and the transepidermal water loss, TEWL, is high, so that even mild heat or cold can destabilize the fluid balance. So that's why we talk about thermoregulation and insensible losses, especially in the NICU. This is not theoretical. This is all very thermodynamically driven. So their barrier is leaky, and their immunity is naive. So this is setting the perfect storm for something like a disseminated herpes simplex or varicella infection to develop, even from what looks like a small lesion on an adult. And eczema, it doesn't need much provocation in this population. A new detergent, a new blanket, even their own drooling and saliva can trigger a flare. Right? So the key takeaway is that neonates don't overreact. They're just reacting too easily. It's nonspecific. Conversely, in the geriatric population, they have this deteriorating defense and slow recovery. So now fast forward 8 decades later, and the skin architecture is collapsing inward. That dermal epidermal junction is flattening out, and they're reducing that shear resistance. So a simple transfer or tape removal can pull that skin full thickness right off. And a decreased sebum and sweat production, that skin becomes dry, xerotic, itchy, fissured. And that's basically a gateway for eczema to develop or an infection, essentially. So immunosenescence adds this double blow. There's a diminished response, and then there's also delayed recognition. So the wound may look deceptively clean because the inflammatory signal never quite lit that fire to cause that inflammation to show. So you won't see the heat and redness and swelling that you may expect, but that infection could be under there smoldering beneath the surface. Okay, so on that last slide, we talked about what the lesion looks like, and now I'm going to talk to you about zoom out a little broader now. How do we categorize and label what it is we're seeing and where we're seeing it? So if morphology is what it is, then distribution is where and why. What story does the map of the body tell you? So don't just list lesions. Now you want to go further and locate them, because that pattern is often the clue to a diagnosis. So the first thing you want to look at here is the difference between extensor and flexural surfaces. So start simple. Elbows and knees, that's the outside or inside. Extensor surfaces, those are your elbows, shins, knees, scalp, etc. Psoriasis loves it there. Those are well demarcated plaques with a silver scale. And then there's flexure surfaces. That's like the antecubital fossa, the popliteal fossa, the neck behind the ears, maybe the eyelids, and atopic dermatitis loves to live there, especially in kids. Thin skin, sweat, friction, all of that sets the stage for this T helper 2 heavy immune mediated pathway that is typically responsible for this atopic dermatitis. Another thing you want to talk about is the photo distribution of whatever it is you happen to be seeing. So you're asking basically is, would a t-shirt have protected against this? Do you see like a sharp V demarcation on the chest or the dorsal forearms, or the face? Does it spare under the chin or the upper eyelid? Right? Because what that is where the sun doesn't shine, essentially, right? So photosensitive drug eruption or cutaneous lupus. The border between sun-exposed and covered skin is a huge clue as to what may have been the offensive agent here. Another thing to describe when you're looking at a lesion, the dermatomal or herpetiform distribution. So ask yourself, does this lesion respect a nerve map? Does it follow a dermatomal pane that becomes a vesicle, usually not crossing the midline? Well, that could be classic herpes zoster, right? But if it's a grouped vesicle on an erythematous base, especially around the mouth or the genitals, that's like a herpetiform distribution. So think HSV, some basic morphology, but the pattern and location will separate zoster from herpes simplex. And then another thing to comment on is the linear angulated versus systemic xanthum. So the next thing you want to ask is, could a plant or a watch band or a patch have traced this? Linear angulated streaks along an area of exposure, like say on the forearm after gardening, under a bracelet, under a bandage, all of that is fitting that allergic contact dermatitis picture. So urushiol from poison ivy, that's like the classic. I brushed up against it. I didn't know it happened. Then all of a sudden there's this rash developing. In contrast, if you have this symmetric, photo distributed, macular papular rash, say over your trunk and your extremities, well, that's going to say this is not localized. So this must be some sort of systemic situation. So there's a systemic driver of this. That could be a drug eruption or a viral xanthum or some sort of autoimmune disease. And the other thing we always want to ask about lesions and things we see, is it blanching or non-blanching? That's called dioscopy. So what that means is you're going to take a clear disc and just press it up against the lesion so you can see through it. And if it doesn't blanch, or it blanches, but you can see by applying pressure. If you do it with your finger, when you remove it, you miss the blanching part. So that's why we do it with a slide. But don't forget this 2-second bedside test. Does it disappear under pressure? And blanching lesions equals vasodilation and erythema and urticaria, right? But if it doesn't blanch, that means now you're dealing with something that's trapped, like a red blood cell maybe. So now you're thinking maybe purpura or petechiae. So you can think platelets or coagulation problems or vasculitis. Those little tiny things are going to help you have some way to describe and eventually think about how to treat the condition. So you always want to start every skin exam with a total body map. You want to look at extensor surfaces and flexure surfaces. You want to consider, is this sun exposed or shade? Is it dermatomal or diffuse? Does it look like a contact tracing? Is it symmetrical? Do the blanch test. Ask about the morphology. All of this will get you closer and closer and closer, because then you can pull up an app on your phone like Visual DX and start typing in these descriptors, and it will start to show you pictures of what this possibly might be, and you could be on your way to a clearer diagnosis, or at least a clear description for when you make that dermatology referral. And depending on how good the description is, you may get them in sooner than later, because right now it's a year for a total body skin check if you're just looking to get into derm in New York City with your insurance. Okay, so let's talk about some of these bedside diagnostics. I've not worked in dermatology, so I'm just going to give you an overview as to how this works and what they're doing, essentially. These are some simple office-based diagnostic tools. So the first one for you to look at here is this KOH prep. And what this is for is to detect fungal elements. So what we're looking for here are branching septate hyphae dermatophytes. Dermatophytes are what we call tinea. So where you will see this will be on a pathology report. So you'll see dermatophytes. The other thing might be pseudohyphae with budding yeast. That's consistent for Candida species. The way this is done is you just scrape the active scaly edge of a lesion with a slide, and then you place it with a 10 to 20% potassium hydroxide agent, and then it's warmed briefly and they look under the microscope. And what you're looking for here are these scaly plaques, and they could be suspicious for tinea corpus, tinea pedis, onychomycosis, intratracheous rashes, where Candida is on the differentials. Keep in mind, if they've started applying topical corticosteroids at home because it's over the counter, that can mask and enlarge tinea. So tinea incognito, that's called. So the KOH prep is what's going to confirm this. So because you can't see it on the skin with the naked eye. Another bedside test, which is popularly done, although now what's more commonly done is you just treat the person rather than wait for this. This is more academic in nature, but definitely helpful. So this is a Zank smear. This is where you're looking for multinucleated giant cells, suggesting a herpes simplex virus, HSV or VZV. And so you select a fresh vesicle, and then they gently scrape the roof, that is, pop it, cut the roof off the top of this vesicle, and you want to take that moist base on a slide, and then they stain it, and they look under the microscope, and they're looking for basically grouped vesicles on an erythematous base. And a positive Zank is not type specific, but it can support herpetic diagnosis, so it just justifies treatment. It will just tell you in clinical practice if I suspect it's herpetic or shingles, they're going on the valcyclovir until proven otherwise, because you really want to treat that in the first 72 hours for best outcome, but something to keep in mind. Dioscopy I previously described to you. That's when you press the slide up against the skin and see if it blanches. Skin biopsy, this is the definitive diagnosis, obviously. Some can be done by NP, some are done by dermatologists, depending on where you wind up working, but this allows for direct immunofluorescein to define, is this autoimmune, vasculitic, malignant, etc. Okay, this is one of the most common conditions that occurs. You will see this written up, and and euphemistically, atopic dermatitis and eczema are used interchangeably. Atopic dermatitis can be understood as two problems interacting. You've got that leaky barrier situation, but also this type 2 inflammation, okay? So filaggrin and the barrier. Filaggrin here is the key structural protein in the outer epidermis. It's produced as profilaggrin in the keratohyalin granules, and this gets processed into filaggrin. Now, what's the point of all this? Well, this filaggrin bundles the keratin filaments inside the corneocytes. So why this matters is because this helps seal that stratum corneum. And this breaks down into natural moisturizing factors, keeping the skin hydrated and slightly acidic. When filaggrin fails or is deficient or mutated, the epidermal barrier becomes impaired. So you have this increased transepidermal water loss, and the skin pH goes up, meaning more alkaline. And so you have an easier entry point for various allergens, microbes, and this barrier abnormality is that starting point for atopic dermatitis. So Th2 and the inflammation cascade, this is the same Th2 we saw in pulmonary, the same Th2 cascade we saw in GI. It keeps coming back. This is the dominant program here. This is an IL-4, IL-13, and what this does is it's promoting this IgE class switching in beta cells. So the eosinophils are recruited, and the skin conditions that favor staphylococcus colonization have now been set. The stage is set for this. So this type 2 access is driving what they're complaining about, itching and eczema plaques, and that's what drives those recurrent flares that you see over and over again. What we're describing here is something called the atopic march. This is atopic dermatitis, often as the first step in the march. The same Th2 pathway can progress from atopic dermatitis, from food allergy, from allergic rhinitis and asthma. That can also trigger cutaneous reactions, GI, respiratory manifestations. And it can target different organs, but basically it's all from that Th2 activation. There is an age-related distribution pattern with atopic dermatitis, and atopic dermatitis is sometimes called eczema. So in children, infants, you'll typically see it flare up on the extensor surfaces. In infants, on the extensor surfaces. Now, children, you'll see them on the flexure surfaces. So that's going to be between the fingers and the antecubital fossa and the popliteal fossa and the like. Adults, they get this lichen-filled focal plaque in areas of chronic scratching and friction. So these patterns will reflect maturation of the barrier and mechanical forces and habitual scratching. So depending on age and their behavior is where they may see things. So you might say, does it itch? No. Why are there streak marks right there on your arm? Surely it itches. Or maybe they're scratching when they sleep and they don't really know it. So that's something to pay attention to. So the basically what you're going to do for atopic dermatitis is you want to restore that barrier. So how do you do that? What's the purpose? You need the emollients. You need structured bathing routine. Don't overwash. Moderate that temperature. You want to reduce the T2 inflammation with topical anti-inflammatories. Maybe some biologics are indicated. And the reason I list the IL-4, IL-13 is because when you get to pharmacology and you look at the different classes of biologics, what you need to do is look at mechanism of action and pair that with pathophysiology. You don't just want to take Madison Avenue in the ad campaign and do things like Pepsid heartburn. H2 blocker. No, Pepsid not heartburn. Pepsid is H2 blocker working on histamine 2. So same thing here. When you get to the biologics, you will see those commercials, works on IL-4, works on IL-13, etc. Now you know exactly what it is we're targeting and what symptoms are responsible based on that cytokine pathway. Okay, let's take a look here at contact dermatitis. Now, this is very popular. Contact dermatitis can either be an irritant or an allergen. So your question is first, is this damage or is this memory? And if the reaction is due to direct chemical injury, then it's an irritant contact dermatitis. But if it reflects a T cell memory response to an allergen, then we call this allergic contact dermatitis. Okay, so irritant contact dermatitis, ICD, the mechanism of this is direct cytotoxic injury to the keratinocytes. This triggers the release of the innate cytokines like IL-1 and TNF. Remember the smolderers in the background doing inflammanogen. So what happens here is the patient will often describe a burning or stinging more than an itch, because this triggers nociception. Those nociceptors are activated by the chemical damage. The barrier disruption is greatest where the exposure is highest. So typically on the hands or any occluded wet areas. So on exam, you expect to see things like erythema, dryness, and fissuring at the contact site. Under gloves, in diapers, in compression garments, tight synthetic shorts, occlusion and retained sweat are amplifying the penetration of the irritants so that the dermatitis is worse. You should also know that ICD is dose dependent. So the stronger and the longer the exposure, the more intense the inflammation. So symptoms can begin within minutes to hours, and there is no need for a prior sensitization here. So common triggers for irritant contact dermatitis would be things like soap, detergents, solvents, surfactant strips, lipids, caustic agents. And what they're doing is they're leading to barrier collapse with burning, chafing, chapping, cracking. One common manifestation in men is in the inguinal region. So what happens is you'll get occlusion and sweat and friction, and that increases the risk of irritant dermatitis secondary to fungal infection. So with all the rage of compression shorts, trapping heat and moisture creates this persistently occluded wet environment. Contrast that to, say, a jockstrap, on the other hand, where it's more open, less occlusive, allows for airflow, quicker drying. So for men with recurrent groin rash or those wanting to avoid the situation, recommending the less occlusive athletic supporter rather than, say, compression shorts can reduce those flares and frequencies. But we live in the information age where no one's going to wear them and everyone's afraid of their own body. So c'est la vie. Here's a cream. Allergic contact dermatitis, on the other hand, you have this type 4 delayed T-cell mediated reaction. So these are small chemicals like the poison ivy, the nickel, the fragrance, the preservatives, the adhesives, etc. And these act as haptens, and haptens bind skin proteins. The Langerhans cells present these complexes to the T cells and create this immunologic memory. So on re-exposure, the sensitized T cell responds, but not immediately. The flare typically appears in about 12 to 72 hours after the exposure, reflecting the time needed for the T cell recruitment and cytokine release. This cytokine-driven spongiosis in the intracellular causes intracellular edema in the epidermis and produces this intensely pruritic eczematous plaque with microvesicles, and it's oozing and crusting. And here, the itch is the dominant symptom. So the antigen maps the rash. So it could be linear angulated streaks suggesting like they brushed up against a plant for, say, poison ivy. It could be shaped like the item. So like it could look like the wristband they're wearing or the watch or the earring or the belt buckle. This is the allergic dermatitis. It could be just where they apply the fragrance. So the fast way to distinguish this, onset, number one, irritant contact dermatitis, minutes to hours after exposure. Allergic contact dermatitis, 12 to 72 hours after exposure. The primary sensation in irritant contact dermatitis, burning and stinging. In allergic contact dermatitis, it's pruritic itching. The pattern for irritant contact dermatitis, it's diffuse overexposure, heavy or occluded areas. In allergic contact dermatitis, it's linear, angulated, item-shaped, matching the contact map of the allergen. And the dose response. So in irritant contact dermatitis, it's a clear dose relationship. The longer it's occluded, the longer it's wet, the longer it irritates. With allergic contact dermatitis, a little goes a long way. Tiny amount can trigger this large reaction, completely out of proportion. And then, so what you want to do is you want to match what the patient feels with how quickly it started and where it appears. And that will help you understand what that underlying process is. Chemical cytotoxicity for irritant contact dermatitis versus T-cell memory for allergic contact dermatitis. This will allow you to more easily classify the diagnosis. All right, so now we have to ask the question, which layer is failing here? So in venous stasis disease, the primary failure is in the dermal microvasculature. That's the superficial veins and capillaries within the dermis, not the epidermis. So what's happening is these venous valves are leaking, leading to venous hypertension. And there's dermal capillaries get distended and leak plasma and red blood cells and leukocytes into the surrounding tissue. The result is this dermal edema and inflammation, and then secondarily you get this breakdown in the epidermal layer, and that's what produces that stasis, dermatitis, and eventually ulcers. So if you think about the venous hypertension leading to dermal edema, the patient will report what? Heavy, aching legs, worse at the end of the day, relieved by elevation. And then you do an exam and you will see things like pitting edema, erythema, scaling, weeping skin around the ankles. You might see evidence of leukocyte trapping, which manifests as stasis dermatitis. Trapped leukocytes release those cytokines, inflaming the dermis and then overlying the epidermis. And what will they complain of here? Pruritus, more than pain. And so the exam will be ill-defined. The other clue here is that they typically will have this on both sides. Both legs will have this. That's important because if it's one leg, your differential needs to change a little bit. Often bilateral. With plaques and scales, it could be oozy and crusty. That's helpful in distinguishing because if it's unilateral, hot and tender, now you're thinking cellulitis instead of venous stasis. So that's an interesting way to help distinguish that. You're also looking for signs of red blood cell extravasation. So red blood cells leaking from the dermal capillaries will break down and deposit hemosiderin. And so the exam will show you things like a brown, brawny skin, hyperpigmented, and it doesn't blanch. So that's why you're seeing what you're seeing. There's this chronic inflammation, which is long-standing, and what that does is it remodels that dermal fat and fascia under the skin. And so what the symptom associated with that will be tightness and shrinking of the calf. And the exam will show you like this woody induration and this inverted champagne bottle looking lesion on the skin. And the contour might show you things like a porcelain white scar, and you'll see some atrophy blanching. All of that is indicating that there is poor microcirculation. And then the dermal pressure with the fragile epidermis leads to those venous ulcers. So you'll have sustained venous pressure and a thinned epidermis, which can eventually lead to ulceration, typically around the inner ankle. Okay, and the symptom there is going to be shallow pain with drainage. The ulcer will be irregular in shape, and that's a good way to help you distinguish it from an arterial ulcer, where it tends to match the pulse point and it's punked out and it's a very crisp margin. The venous ulcer margin is it looks kind of like a lake that's kind of meandering a bit. It's not quite as clean bordered. And therapy, of course, is going to be compression, elevation. What you're trying to do is undo a lifetime of damage. You want to restore that venous competence, bring the swelling down, let the skin be hydrated, close it up. You want to avoid putting steroids on open wounds because they will limit healing. All right, let's talk about here psoriasis. Now, psoriasis is it's not just a rash on your elbow or your knee. This is a systemic disease state. Psoriasis is built around a focused immune circuit. So this starts with the dendritic cells releasing IL-23, and IL-23 is sustaining the T17 cells. And these T17 cells are producing IL-17 and IL-22, which are pushing these keratinocytes into overgrowth. I don't need you to memorize this. I just need you to know what's associated with this inflammatory cascade we call psoriasis. Now, this one loop explains both the histology and this classic exam finding. So this starts with dendritic cells in the skin. This including the Langerhans cells. So when these are activated, the cell presents an antigen and secretes that IL-23. Well, IL-23 doesn't initiate the Th17, but it does maintain it, and it stabilizes and expands them. So the more IL-23 that's being released, the more Th17 cells are manifesting these louder psoriatic signals. So that Th17 subset is programmed to make the IL-17A, F, and IL-22. Once this population is expanded, the skin is bathed in cytokines. So I'm going to bring this all home to you and help narrow this down. I'm just giving you the cascade so that you can know what these modifying drugs are working on. IL-17 and IL-22 are the main effectors in psoriasis. So hang on to those two, IL-17 and IL-22. IL-17 is driving keratinocytes to release chemokines, and chemokines recruit neutrophils and boost the antimicrobial peptides. IL-22 tells the keratinocytes to proliferate rapidly and delay maturation. So what do you think you're seeing on the skin but this proliferation of keratinocytes? Together, these produce the two key histologic changes: acanthosis, which is that epidermal thickening, and parakeratosis, which are those essentially patchy, scaly things you're seeing associated with this. Okay. And this is what gives you that thick, ardent, silvery, scaly patch that you can feel at the bedside. This is why underneath the plaque, that's what you're seeing, essentially. It's a result of this inflammatory recruitment. Okay. So this shows up as what we call commonly plaque psoriasis. Okay, plaque psoriasis is this sharply demarcated erythematous plaque with a silvery scale, and most often on the extensor surfaces, elbows, knees, scalp, lumbosacral region. The borders are so clean because the cytokine field has a boundary. Inflammation and the keratinocytes, hyperproliferation stops abruptly right at the edge where IL-23 and Th17 are signaling. So the thing you need to know about psoriasis is this is not just a skin condition. Because the IL-23 Th17 cascade is in progress, once this pathway is on, it inflames the skin and deeper structures. So tendon insertion sites, vessels, and the nail apparatus. Now, I'm going to talk about each of these because each part tells you something different. Psoriatic arthritis. Enthesis biology is this. So enthesis, by the way, is the insertion point of the tendons and ligaments into the bone. So this cytokine is triggered, this enthesis, and that what happens is that's driving an influx of neutrophils and new bone formation. So where this will play out clinically, and you can tell if they have this, you see the plaque on the skin, one of the questions you want to ask is, do you have heel pain at the Achilles or plantar fascia? That's going to be the tell that tells you that there is enthesis involvement. You're also looking for dactylitis, that is sausage-looking fingers, and asymmetric DIP arthritis, distal interphalangeal joint. That's the distal knuckle on your finger before the tip. So ask every psoriasis patient, are there any swollen fingers or toes, heel pain, or morning stiffness lasting more than 30 minutes? Because if it's positive, or if they have nail disease that's prominent, you need to consider imaging, ultrasound, MRI, and this is the person that you're going to think about early referral to rheumatology, because these are the ones that are going to need to be managed with the biologics. And you need to address the skin and joint inflammation because they have a shared pathway. Another thing that people don't immediately know about psoriasis is this is related also to metabolic syndrome and cardiovascular risk. There is a low-grade systemic inflammation. So that chronic Th17, TNF, IL-6 signaling is altering the adipokines. It increases leptin and is reducing adiponectin. And this promotes insulin resistance. There's an endothelial dysfunction, and this is accelerating atherogenesis. So the same inflammatory machinery seen in the vascular plaques is being triggered by this inflammatory cascade. So if you notice on a patient with psoriasis, the central adiposity, the middle body fat there, pre-diabetes or diabetes, hypertension, dyslipidemia, they may have a higher than baseline CRP level, and they are prone to earlier cardiovascular events compared to their matched controls. So you need to treat psoriasis as an independent cardiovascular risk enhancer. So you do a quick ABCDE checklist on them when you see them, right? A1C, because that's going to tell you about atherosclerotic cardiovascular disease. Blood pressure control, cholesterol, statin if needed, diet, weight, depression, got to deal with those, exercise and smoking cessation. Because if you can effectively control those inflammatory pathways, the IL-23, IL-17 axis, this can improve the inflammatory burden and help you manage that cardiovascular disease more effectively. And you just don't let it go. It's not just a skin condition, because that's all they're bothered by. Now, the other piece of this you need to pay attention to is if the psoriasis is involving the nail, there's an anatomic bridge to joint. So inflammation hits that nail matrix, leading to pitting and ridging, and can travel along this enthesis organ, and that connects the nail to the DIP joint. So the nail is just before that DIP joint. And that anatomical continuity is the reason we are having psoriatic arthritis. You can see how that pathway is connected. So ankylolysis, oil spots, pitting often coexist in that DIP joint. And so nails are a red flag. Their involvement markedly raises the risk or the probability of psoriatic involvement when you look at somebody's nails with psoriasis. So you do want to document nail findings, and you want to feel the DIPs, and then that also may help you escalate this to rheumatology as well. What this is doing is giving you an idea of how contained is this disease process. Can I manage it in primary care, or do I need to refer it to a subspecialist? Okay, now let's talk about what everyone loves to hear about, because they're going to make a whole business based on acne vulgaris. Okay, so acne is stubborn. And the reason it's stubborn is because this is four processes running at the same time. And what happens is each process amplifies the other. And the problem is we only like to do a little. The problem is if you only help a little and treat one pathway, you've got three others working against you. So the first one is this follicular hyperkeratinization that forms the comedones. And this is the keratin plug at the follicular opening. And what you'll see are blackheads. If you see blackheads, that's an open comedone. If you see whiteheads, that's a closed comedone. So your target fix here is topical retinoids, and you want to normalize that keratin turnover and unplug the pore. Okay, so something like adapalene works just fine. Okay, now the next pathway you need to target here is this Cutibacterium acne proliferation. So this is that inflammatory stage. So this is that plugged lipid-rich follicle, and it's a perfect anaerobic medium for bacterial enzymes to trigger that cytokine storm. And what you're going to see and feel, you'll see these tender papules and pustules. And so what you need to do here is this is what the benzoyl peroxide is for. Okay, so you put the benzoyl peroxide, you put the adapalene at night, put the benzoyl peroxide during the day, plus or minus clindamycin. If you do use clindamycin topical, you do always want to pair it with the benzoyl peroxide because it may decrease the length and duration of needing it, and so we want to do good antibiotic stewardship and not build resistance and set the stage for fungal infection, etc. The third mechanism at play here is popular during puberty and perimenopause. This is the sebum overproduction, androgen-driven. This is also popular in the cyclical cycle of menstruation. So androgens stimulate the sebaceous glands, and more oil feeds that plug and the microbes. So you see these shiny, oily skin, and it flares around major hormonal shifts. So the targeted fix here is hormonal modulation. Where else do you see this? All the men running to the testosterone clinics are suddenly having acne again, because basically they're throwing themselves into puberty and they're like, what is all this? So I got a guy that gets the pellets put in, and now he's gone on to being put on Retin-A. Great. So now he's basically reversing. I'm like, can't we just reduce the testosterone dose and see if this gets better? He's like, oh yeah, maybe I could, except the testosterone clinic doesn't want to reduce the dose because the higher they sell, the more they make. So we got to get them treated more effectively. But suffice it to say, this stage is treated with hormonal modulation. So typically in women, you will put on oral contraceptives and spironolactone, androgen blocker, and regulate the cycle. Incidentally, if you prescribe spironolactone to a childbearing age woman, you want to make sure there's oral contraception because it is teratogenic. Now, the final stage here is this follicular wall rupture. These are the deeper lesions that cause scars. And when the pressure rises and the wall breaks, you get this keratin bacteria spill over into the dermis. And what you're going to see is you're going to feel these nodular cysts, and you'll get this post-inflammatory hyperpigmentation, and then you see scarring. So ideally, you want to prevent this stage from happening. But really, if this is you, you don't want to pick at these and squeeze them, because the more picking and squeezing and manipulation you do, the more likely you are going to be to scar. All right. Now, here are some other skin infections we need to talk about. We're going to go from superficial to deep. And the superficial one here is something as simple. So we're starting at the epidermis, then we go to the follicle, the dermis, the subq, and then the fascia. Okay. So as the infection dives deeper, you're going to see more pain, more systemic signs, and more urgency to climb this thing up the ladder. So impetigo, this is a superficial epidermis infection. Okay. Typically staph, it's exfoliative toxins that split that superficial epidermis. And what you're going to see in clinical practice is these honey-colored lesions on the erythematous base with minimal pain. This is highly contagious. And first thing you want to do here is debride it, clean it up, wash, and maybe some topical mupirocin for a limited course. If it goes into the oral area, then maybe you need to think about oral agents and prevent extensive outbreak. Okay, so that's impetigo. The next step down would be folliculitis. And here we're talking about furuncles and carbuncles. Now, This is a deep follicular infection. This basically starts in the follicular unit. Pressure builds up, the wall breaks down, you get a dermal abscess. We call that a furuncle. And then a carbuncle is where it coalesces a bunch of different furuncles. So a furuncle is one, a carbuncle is a coalescence of furuncles. Got it? Good. And with multiple draining tracts. And the typical offensive culprit here is Staph aureus, but you always have to be open to the possibility of MRSA. And so what you see is going to be these tender papules and pustules at the hair follicle. They could be fluctuant nodules surrounding with erythema. And you will treat this with a warm compress. So long as it's non-fluctuant. Non-fluctuant means you press on it, you don't feel it jiggle. Think like ascites, but on your hand. Okay, something like that. So for a fluctuant abscess, essentially, this is going to need incision and drainage, and you're going to have to provide some anti-MRSA coverage as well. And you want to make sure they don't develop systemic signs and symptoms, and you want to follow whatever decolonization protocols are in style today. The next layer down, we're going to go to cellulitis, and this is dermis and subq. And so this is typically streptococcal spread rapidly through the dermal lymphatic system. Staph is a little less common. The entry points for this is wherever you break the skin. So fissure, ulcer, bug bite, tinea pedis, trauma, edema, fill in the blanks. However you broke the skin, you introduce the bug, and we're off. So there's this ill-defined, warm, tender erythema with swelling, and you may have systemic symptoms like fever and lymphangitic streaking. You may be seeing a sharp raised border looking like erysipelas. So what you do first when you see cellulitis, raise your hand, you mark the border, right? So you draw a circle around that border so you can track how fast this thing is going. And you mark that border, and you want to provide empirical coverage with broad spectrum antibiotics, and you want to reassess this every 24 to 48 hours. And pay attention, by the way, if you see this on bilateral shins, reevaluate your diagnosis. This may not be cellulitis. This could be venous stasis ulcers. Okay? And we call that pseudocellulitis. The difference is that doesn't need antibiotics. And then the most horrible thing in the world with respect to skin, which we all live in fear of, is this necrotizing fasciitis, flesh-eating bacteria here. So this here is life and limb threatening. Don't miss this one. Okay, this is a polymicrobial group A strep and staph. This is toxin synergy. Microvascular thrombi are forming here, causing ischemia. And this is letting that infection race along all the way to the fascia, and the skin may look deceptively clean. So what you see here is the patient's going to report pain greatly out of proportion to what you expect. And there's going to be rapidly advancing erythema and edema and this tense woodiness of the subcutaneous tissue. You may also see a bulla on the skin. Interestingly enough, the skin may not be sensitive. It might be skin anesthesia over the involved area, and there could be systemic toxicity. When you do a plain x-ray on this, you're going to see gas in the subcutaneous crepitus look like subcu emphysema on the x-ray. That's a late sign, but that's like oh my God, you need a surgical consult. So quickly in the OR, because the treatment is debridement and broad spectrum antibiotics, and this you need to be aggressive because it could be fatal. If this happens in the groin, by the way, they call this Fournier's gangrene. And this is going to kill you. This is a surgical ICU patient there. So pay close attention. And how can this happen? It's a break in the skin that's not tended to, essentially. So any sort of grooming, hair removal patterns, it's not cleanly done. You didn't use the same razor. The wax was double dipped. Whatever your problem is, that can set the stage for this sort of thing. So ask very detailed questions, assume everything, and assume nothing. Okay, let's talk about these viral infections here. So when you see a rash, it helps to ask yourself which organism lives in which area of the skin and what pattern does this thing create. So I'm going to start here with the dermatophytes. So these live in the stratum corneum, and these things make keratinases that digest keratin. ACEs digest tin. ACEs are enzymes, right? They break things down. And slowly these invade that outer epidermis, Clinically, this gives you an annular scaly plaque with active raised edge and that central clearing. What am I describing here? Well, this is the classic ringworm look. A bedside KOH prep is going to give you this scaly edge, and it shows branching and septate hyphae. And this confirms that this dermatophyte tinea rather than eczema. And the reason we do that is sometimes eczema can look like this. So if you're not sure, KOH prep helps. And you might see things like tinea versicolor, which prefers a rich lipid area like the chest or the back or the shoulders. You may see overgrowth of this yeast, which disrupts that melanin transfer to the keratinocyte. So you could see this hypo or hyperpigmented macule with a fine scale on an oily trunk skin. And so the KOH is going to give you this, what they call spaghetti and meatballs look. It's going to be short hyphae with mixed round yeast formations. Candida favors moist intriguous skin areas, so the groin and skin folds and inframammary folds and things like that. And you may see things like macerated epidermis, and this sends out pseudohyphae, and it thrives in warm environments that are occluded. So the bedside picture of this is that beefy red macerated patch with statolite pustules at the periphery. KOH is going to show you budding yeast with pseudohyphae, which separates Candida into trigo from some sort of other irritant skin rash. Now contrast this with the first one on our list here, HSV-VZV. This infects the keratinocytes directly, and then it hides in the sensory ganglia and then reactivates later. Now there's HSV-1 and there's HSV-2. The cause, recurrent localized mucocutaneous outbreaks at the same site. Classically, we would say that HSV-1 is orolabial and HSV-2 would be genital. Though practice patterns now blur because people do things where the oral can go elsewhere. And so you can have HSV-1 and 2 where you may not expect to have HSV-1 or 2, okay? And so this trigger can be due to stress, fever, ultraviolet exposure, procedures, episodes last generally a few days. It's recurrent. If they have frequent recurrences, the guidelines change frequently, but now if you have 5 or more in a year, you can go on daily suppressive antiviral therapy and that sort of thing. VZV, on the other hand, this is a two-stage story. So first, VZV, aka chickenpox. So when I was a kid, we didn't have chickenpox vaccine. That's how old I am now. But so I got chickenpox. And that's a primary infection with varicella. And this is diffuse and intensely pruritic. And I got 10 days off of school with this thing. And you had eruptions with vesicles at multiple stages of healing all over the body. And they look like little dewdrops on a rose petal. Sounds pretty itch like hell. And so after that, what happens is the virus becomes latent in the dorsal root or cranial nerve ganglia. And along a neuroaxis is where it lives until you least expect it. And then what happens is years later, without warning, cell-mediated immunity triggers and your immunosuppression factors wave and boom, you reactivate zoster, which is this painful unilateral dermatomal band of vesicles that doesn't cross the midline. That's a really important thing. Does not cross the midline. And complications can include what they call post-herpetic neuralgia, ophthalmic zoster, dissemination in the immunocompromised host is common. And the next time we're in person, you can come take a look at my shingles on my forehead here where I had it and it went into my eye. And because it was July and I didn't want to deal with med students and I got a cluster headache, I treated it myself. And then I went to ophthalmology and now I have a scar on my iris and c'est la vie, the eyes still work, thankfully. But yeah, so it does flare up when you least expect it. And I was too young for the vaccine. So double whammy at that time. All right, so that is for both HSV and VZV, the treatment is going to be valcyclovir. You want to start it as early as possible, ideally within 72 hours to reduce that viral load and the risk of post-herpetic neuralgia. And if it goes to the eyes, it's considered an urgent ophthalmology referral. So do that. Question, Ashia.
I was just wondering with with shingles, is that the same kind of pathway if you got the if you got immunization and the same risk-ish?
The risk should be lower. So, I mean, the idea is that you don't want to get this recurrence, right? So, if you have the vaccine and you've seroconverted, then ideally you have greatly reduced your chance of developing this. So, if you're over 50, you got to start your shingles series.
Sorry, I meant the childhood vaccine.
Right. That should hopefully reduce your chance of getting it later in life. It can
Oh,
still
okay.
flare up. Yeah, it can still flare. Look, the vaccine is not 100% protective. So you may still contract, quote unquote, the chicken pox, even though you got the vaccine, but it may be less intense and less severe and shorter in duration. But that bug has to get into you.
But having had the chicken pox is 100%?
Nothing's 100%. No, you may never. I mean, the problem is you don't know if you have this until you flare it.
Right.
You don't know, right? I mean, some people never have shingles and have had chicken pox and have not had the vaccine. There are some people like that. So all we're doing is trying to mitigate risk. There is no guaranteed, if you do this vaccine, you're guaranteed not to. It's just you're less likely to. And what affects that is age when you had it, comorbidities, when you got the exposure, when you got the shingles vaccine, if you got the shingles vaccine. So there are a lot of variables there. It's the best I can tell you on that, but there is no guarantee. But here, so if every time someone uses the hotel soap, they end up getting a severe itching, redness, and pimples in both arms, is this allergic dermatitis? Depends on how soon after you use it. So if it's right away, yes. If it's 12 to 72 hours, we're calling that allergic versus irritant. Whoever iPhone was. Put your names in the box. Okay, so let's talk about this. Did we talk about necrotizing fasciitis? We did. Okay. No, we didn't. We didn't talk about this. Okay, let's talk about necrotizing fasciitis. So this is a rapid ischemic necrosis. What's happening here is the bacteria is not just infecting the tissue. The problem is that it's shutting down blood flow to the tissue. So the toxins that trigger the microthrombus in the perforating vessel. And so what happens is this fascia becomes ischemic and the antibiotic cannot reach the destination. So the culprits here are these microbial antibodies that are attacking this, causing this cytokine storm and eventual capillary leaking and shock. So why does immunity fail locally? Well, obviously, if there's ischemia causing tissue hypoxia, that hypoxic tissue is not able to have the neutrophil response, so no oxygen, no oxidative killing, and the infection spreads unchecked along the fascial planes. So the way this shows up is that you will have the pain beyond proportion, and before how the skin looks dramatic, and this will rapidly spread. And you may see a bullivascular occlusion lesion, and this will obviously cause some systemic symptoms later on. And then this could be fatal if not treated aggressively. Okay, another two serious conditions here, one more serious than the other. These are two blistering syndromes that can look similar, but they have a completely different engine. The first one is TEN, toxic epidermal necrolysis. The trigger here is a drug-induced type 4 T cell reaction. This is cytotoxic. And the culprit is often certain medications like sulfonamides, allopurinol, anti-epileptics, like lamotrigine, carbamazepine, sometimes NSAIDs can trigger this. And what's happening is in this toxic epidermal necrolysis is you're having a cytotoxic T cell natural killer cell release to the granulosin, which is triggering a cascade of factors causing this keratinocyte apoptosis. Apoptosis is programmed cell death. And so what happens is you get this level of split, which is a full thickness epidermal necrosis. The entire epidermis is detaching from the dermis. And why this matters is because that raw dermis leads to severe pain and massive fluid and heat loss. And obviously, there's going to be a high risk for infection and sepsis here. Now, it's common to have mucosal involvement here, oral, ocular, genital, because the mucosa expresses the same keratinocyte targets, which leads to those ulcerations. This mostly affects adults. The mortality rate is 20 to 30%. This is very much like Stevens-Johnson syndrome. The distinguishing characteristic is how much of the body surface area is affected, but it's the same pathophysiology. Now, when you get to the staph scalded skin syndrome here, this is a staphylococcal scalded skin syndrome, and this is triggered by a staph toxin A and B. This is toxin mediated, not a drug hypersensitivity. So this is very superficial at the granular layer of the epidermis. And why this matters is because thin scalded sheets will slough off their body, but the basal layer remains. So this will heal very nicely without scarring. And fluid loss is a lot less than if they had toxic epidermal necrolysis, so it's less severe. And who this primarily affects are infants and young children, or it can affect adults with renal failure or immunosuppression who are not able to clear that Staph aureus toxin. Mortality for this is less than 5% with treatment. So these look alike, but they behave differently. Both can have the widespread erythema and the fragile bullae, but in toxic epidermal necrolysis, necrotic full thickness epidermal loss with mucosal destruction, high risk for sepsis, whereas this SSSS, superficial, it's split at the granular layer, and the mucosa is spared. So that's an easy way to tell them apart. The mucosa is spared. Okay. Let's talk about compartment syndrome and cellulitis. So basically the same pathophysiology of cellulitis can ensue, but they're due to infection, leading to inflammation, leading to capillary leak, which leaks inside this closed osteofascial compartment, leading to an increased compartment pressure, which further impinges the circulation. Right? So what happens, obviously, the cellulitis has progressed to the point where you are damaging the ischemic nerve first. The pain is greatly out of proportion, and pain with passive stretch, that is the earliest reliable sign of developing a compartment syndrome in relation to cellulitis. This progressing ischemia can lead to weakness and pulselessness, and the arteries could be under high pressure because the surrounding tissue is compressing it. So don't be reassured by a pulse. I mean, yes, we're more reassured than if there is no pulse, but later signs would be things like pallor, plochiothermia, and paralysis. Look up what poikilothermia is, because that's a great Jeopardy word if you don't know it. But suffice it to say, at this stage, if you get these symptoms, muscle necrosis is underway. Definitive treatment for compartment syndrome is going to be a fasciotomy to decompress the compartment. And if you've had an erection lasting longer than 4 hours, see your doctor right away. Why do you think that is? Because you only have about 6 to 8 hours to revascularize and restore circulation. Same thing in this case as well. So if this is going on for 4 hours, you want to move yourself along to a surgical consult so that we can revascularize and not use the leg or the other. And so the bottom line here is severe cellulitis can tip from edema to ischemia in a closed space. And the bedside trigger to act is that disproportionate pain, especially with a passive stretch plus a tense compartment. I think let's do dress syndrome real quick, and then we will come back. So let's do DRESS syndrome. So DRESS syndrome, this is a drug reaction with eosinophilia and systemic symptoms. So this also is a type 4 T cell hypersensitivity triggered by a new medication. The medication class, they call them aromatic anticonvulsants. Aromatic not because they smell, but because that's a certain ring around their chemical structure. And those drugs include things like carbamazepine, phenytoin, and lamotrigine. Other drugs that can cause DRESS syndrome include allopurinol and sulfonamides, minocycline, dapsone, things like that. So this is an activated drug-specific T cell cytokine response triggering that T2 cytokine chain reaction, which is driving the eosinophils and the atypical lymphocytes, and the immune cascade ensues is triggering injury to possibly the liver, the kidneys, the lung, and the thyroid. This is classic because the onset is delayed. So this is you start the drug and about 2 to 8 weeks later, you start to manifest symptoms. And then a prolonged relapsing course occurs, especially if you taper the steroids too fast. That's the issue here. You're giving steroids to blunt. So you need to think DRESS syndrome when a patient develops a fever, facial edema, eosinophilia, some sort of hepatitis 2 to 8 weeks after a new high-risk drug. This is a T cell driven, and this demands drug cessation and monitoring and steroid taper. Let me see the questions are here. You can look up, it's in the slides, the drugs for 10 as to what causes it, same drugs. Okay, let's do we're going to have to do just a quick break because we have a lot to cover. We still have to finish skin and get through bone. So let's take 5, stand up and stretch, move around, get a drink, and we'll see you back in 5 minutes. Okay. Okay, welcome back. Now we're going to talk about briefly CYP450 and cutaneous drug reactions. Same pathophysiology as previous drug reactions when we talked about DRESS syndrome, but what we're looking at here is this interaction of the CYP450 enzyme on drug-drug interactions and how host genetics can determine whether the drug stays safe or becomes reactive to a skin happening toxin. So reactive metabolite formation, some drugs are harmless until the CYP converts them into a reactive metabolite that then haptenates the skin proteins, and then that immune system sees a neoantigen, and then you get a type 4 reaction. So that's typical of what you'll see in something like a Stevens-Johnson syndrome. And some of those drugs, again, that can trigger Stevens-Johnson and toxic epidermal necrolysis would be something like the sulfonamides and the carbamazepines, lamotrigines, allopurinol, and the like. So the other thing you need to pay attention to here are drug-drug interactions. So some drugs inhibit or raise the parent drug or its toxic intermediates. So for example, if you have an inducer drug, what that can do is it can overproduce those reactive metabolites. So some common inhibitors to remember are things like macrolides, azole, antifungals, protease inhibitors, and grapefruit juice. Those inhibit the 3A4 pathway. And some inducers can be things like rifampin, carbamazepine, phenytoin, St. John's wort. So before you start a high-risk drug, what you want to do is run an interaction checker. Make sure the drugs they're on, including the supplements, are not going to interact. They don't induce or inhibit the pathway that they're going through. And then you want to avoid pairs that raise the exposure or generate more metabolites. And your drug checker will be able to tell you that. There is increasingly a role of pharmacogenomic testing to look for HLA alleles and CYP variants. This seems to be more common in psychiatry than other areas, but suffice it to say, it is a tool at your disposal. And what I want you to take home from this is if you see a new rash plus a new drug, you want to check that high-risk class, and any strong inhibitor or inducer is on board. That's probably going to be your culprit. And if there's any concern, obviously you want to stop the drug and evaluate for any systemic features like fever, mucosa, LFTs, eosinophils, and then you treat according to severity. What you're looking for is what signs do I have of systemic involvement? So This is one of the most serious drug reactions we can talk about. This is Stevens-Johnson syndrome, sister to toxic epidermal necrolysis. The key idea here is this is a drug-triggered, T-cell mediated burn of the epidermis plus systemic capillary leak. Now, this starts with a drug-specific cytotoxic T cell, and the culprit medication is presented to the CD8 T cell, which then homes to the skin and releases these fast ligand granulescins. And so these signal that drive of widespread keratinocyte apoptosis. Basically, keratinocyte apoptosis, that's the programmed cell death of the skin cells. And so what happens is, as the keratinocytes die, you get widespread epidermal loss, and the skin and the mucosa are literally detaching from themselves. And as a result, you get this catastrophic barrier failure where sudden loss of the stratum corneum and the epidermis means that there's a massive impairment of fluid retention, temperature control, and infection defenses. All are lost. Essentially, you are becoming one with your environment, which is terrible. You need to retain your individual uniqueness. So at the same time, there's also a cytokine surge, especially from TNF alpha and IL-6. And what that's doing is it's increasing the microvascular permeability. So what happens is that fluid and proteins are leaking out of the capillaries into the interstitium. And clinically, what that looks like is hypovolemia, hypotension, electrolyte losses. And this can progress very quickly to acute kidney injury and shock if it's not recognized early enough. So the acute care priorities come directly from the pathophysiology that's unfolding. These patients need to be managed like they're major burn patients. So obviously, withdraw the offending agent, regressive fluid resuscitation, meticulous wound care, and you need to turn up the heat in the room because they're not able to regulate their temperatures. Now, with respect to red flags in the skin, so if it's non-blanching, palpable purpura, this kind of is a red flag, assuming it's not a hemangioma. What you're seeing when you have this pattern is blood outside the vessel from an inflamed or an occluded vessel wall. So this is where you start to think of something like leukocyte vasculitis or meningiococcemia or DIC or HIT or endocarditis or IgA vasculitis. That's what this basically means, a non-blanching palpable purpura. So what do? Full vital signs, IV, CBC, coags, etc. You're looking for hematuria, proteinuria, because you're looking for, is this a major systemic reaction? If you see a non-blanching palpable purpura, assuming it's not a hemangioma. Now, the other one is these rapidly evolving variegated pigmented lesions. And why this matters is because this is going to be a melanoma until proven otherwise. Now, this can change over weeks to months, which is fast if you think about what we're talking about here, because biology here is outrunning the local control mechanisms. So this is an immediate referral to dermatology with a good description. They're going to need an excisional biopsy and possible definitive care if this is melanoma. Another one that's a red flag you need to pay attention to is a painful, tense bullae plus or minus mucosal involvement. Why this matters is because painful blisters can suggest a full thickness keratinocyte death, something like a Stevens-Johnson or a 10, and or autoimmune blistering disease. If there is mucosal involvement, then you're going to treat it as if it's a Stevens-Johnson or a tumor or a 10 syndrome until it's excluded. So obviously stop the offending agents and treat accordingly. And this erythroderma here, why this matters is because what this condition is, this means it's extended over 90% of the body surface area. And this is global barrier failure. Erythroderma is global barrier failure with major thermoregulatory and fluid loss. So some common causes can be severe drug reactions or a cutaneous T-cell lymphoma or psoriasis or an eczema flare can trigger all of these things. But this is definitely admit the patient and intensive monitoring and treatment. So the two quick safety checks to keep in mind: blanching versus non-blanching. Press on it with a glass slide. If it's non-blanching, it's outside the vessel that needs some escalation. And if they are sick versus well. So do they look toxic, hypotensive, severe pain? That's time critical. Treat while you work up at the same time. Okay. Okay, let's talk about kids because, lifespan course. So why kids behave somewhat differently. So what you do with children is you're going to start with the barrier. And in infants and young children, the stratum corneum is that thin and leaky. And so transepidermal water loss is higher in children. Irritants and allergens can penetrate more easily, and babies dehydrate and flare faster than adults. Their immune system is also Th2 based, biased in early life. So they have more IL-4 and IL-13. So the deck is stacked in favor of some sort of eczema inflammation. So if you put those things together, you get this atopic march of barrier failure, letting in allergens, increasing the T2 wiring, which keeps inflammation going. That's what leads to eczema and food allergies and allergic rhinitis and asthma. That's why they say maybe they will outgrow it, because as the immune system matures, this may then be less sensitive. So, in children, what we do is you want to grease them up. We use heavy emollients. We address the staph colonization if they're infected. They can do bleach baths or anti-staph measures. Bleach is just very low dilute. You can start topical anti-inflammatories early, steroids and the like. And you want to obviously avoid triggers and go fragrance-free and short lukewarm baths and cotton layers and the like. Okay, that's the management for children. For pregnancy, now hormone and mechanics are at play. So estrogen and progesterone can stimulate melanocytes, which is why we will see melasma on the sun-exposed areas. So counseling here is just broad spectrum sunscreen every day, UV avoidance. Mineral sunscreens are first line and stronger. Depigmenting agents are usually deferred until postpartum. And if possible, striae are just essentially normal dermal tears, and rapid stretching plus cortisol and estrogen affects the collagen and elastin, so you get this linear atrophy. So some pregnant bellies may get very itchy at times due to that stretch and unable to hold moisture. So what you do there is you're going to pick pregnancy safe topicals. If needed, low potency to mid potency steroids, moisturize aggressively, manage the itch with non-sedating antihistamines like cetirizine, loratadine, and always want to coordinate with OB before starting any systemic therapy here. All right, let's take a look at this quick case here. So, we talk about geriatrics and then we'll do the case. So, in the aging population, the skin structure, the moisture supply tends to fail at a different point. So the first thing is the structure. So the shear problem. With age, the dermal epidermal junction is flattening, and what happens is these ridges are lost. And so this results in that epidermis that can slide over dermis with very little force. So you get classic skin tears and flap injuries, something from as simple as a transfer or tape removal or friction against the bed. So what you want to do is avoid strong adhesives, use silicone or paper tape, lift rather than drag during transfers, and use long sleeves and padded rails for high-risk patients. The second issue is this thing of supply, the ischemia problem. There is less collagen and elastin and microvascular density. So the scaffolding here is fragile and blood flow is limited. So that means slower healing, ischemic vulnerability, and easy bruising, especially in patients on steroids and anticoagulants. So what you do is you want to aggressively offload any pressure points and treat any venous edema with compression and elevation when arterial flow is adequate. If they're diabetic, obviously you want to control the A1C. And then the other thing is you want to ensure good protein intake, hydration, and the like to optimize repair, the likelihood of repair. And then third is this moisture retention. So xerosis and itching, you need to break that cycle. So decreased sebum and sweat is leading to that dry skin, which causes the pruritus and scratching excoriations and sets the stage for secondary infection. So obviously thick emollients, petroleum, urea, right after a lukewarm bath, humidify the room, treat the itching with cetirizine, because if they scratch and break the skin, we set the stage for infection. Okay, let's take a look at this case. This is a 68-year-old who was started on Bactrim, say 10 days ago, and now this person has fever and diffuse painful erythema, mucosal erosion, flaccid bullae, and the timing plus the triad of painful skin lesions plus the mucosa and a new high-risk drug tells you that this is going to be treated as if it's Steven Johnson or 10 until proven otherwise. And so the pathway in one line is this drug-specific CD8 T-cell trigger. And then what happens is you get this keratinocyte apoptosis and a sheet-like epidermal loss. The capillaries are leaking, you get hypovolemia and risk acute kidney injury. So the treatment obviously is stop the culprit, which is the Bactrim, and then now recorded as a severe allergy. Don't forget to do that because they could wind up on it again. And then you treat them as if they are a severe burn with, and sometimes IVIG and cyclosporin, depending on the local protocols. But the bottom line is you are going to move quickly and put a story together. All right, that was skin. Now, stand and stretch and stand and cheer, we're going to do bone. Now, bone is not just rock you're carrying around in your body. This is living composite material. It's made up of hydroxyhyphenate mineral laid on top of type 1 collagen scaffolding. And this is built into two main architectures. There's cortical bone. That's what gives you the strength and rigidity. And then there's trabecular bone, which is lighter, more porous, and serves as your metabolic fast turnover reserves. Now, 3 cell types run this system. You've got osteoclasts from the macrophage lineage. These are the resorbers. They dissolve mineral and chew pits into bone. That's the osteoclasts. They are turned on by rankle, and they are held in check by OPG, and we'll get into what that is. The other cell type you have are osteoblasts from the mesenchymal precursor, and these are the builders. These things lay down the unmineralized matrix, osteoid, and then you have, and they mineralize it. So these are the blasts that become osteocytes, and which are former osteoblasts buried in the matrix. Osteocytes are the strain sensors through signals like sclerostin. And what happens is these put the brakes on the pathway that throttles bone formation up or down depending on the load. We'll explain all of this as we go through this. So what happens is bone, together with these remodeling pathways, have a cycle of osteocyte senses, micro damage, or unloading, and then this sends that activation signal. Osteoclasts resorb and create pit over 2 to 3 weeks. And so there's this brief reversal phase, a kind of handoff where you have osteoblasts move in to refill the defect and mineralize it, and then that process takes months. So knowing how long that process will take will be helpful when we talk about bone fractures, healing, and delayed healing. So there's this continuous coupled cycle of resorption and then formation. And it's what we'll keep coming back to when we talk about things like osteoporosis and steroids and endocrine disease and the different drugs we use to protect or rebuild bone. All right. So once we know how bone remodels, the next question is who's pulling the levers? So bone health is essentially a 3-way negotiation between hormones and nutrients and the bone cells themselves with the mechanical load they need to bear. So there's an endocrine side to this. That's mediated by the PTH, vitamin D, calcitonin, sex steroids, and glucocorticoids. And that's what we're talking about when we talk about metabolic bone. Now, the parathyroid hormone is a great example of dose and timing. So what happens is continuous elevations of PTH push osteoblasts to express more rankle, receptor activator of nuclear factor K ligand. So from now on known as rankle. And OPG will be known as osteoprotogenerin. Now, what happens is this continuous elevation pushes the osteoblast to express more of this rankle, driving this osteoclast-mediated resorption, while intermittent pulses can be anabolic. The role of vitamin D is that it increases calcium and phosphate absorption. When it's low, the body's compensating with secondary hyperparathyroidism. That raises turnover. Calcitonin has this modest anti-resorptive effect, and sex steroids, especially estrogen, help restrain osteoclast survival. So at menopause, we will see a jump in high turnover bone loss. And when someone goes on long-term glucocorticoids due to the opposite of what we want, they suppress osteoblasts and osteocytes and increase resorption. So steroids suppress osteoblasts and osteocytes and increase resorption, leading to rapid bone loss. And in a condition like thyrotoxicosis or CKD, where there's a mineral bone disorder and malabsorption, you can see how there are many ways that the endocrine system and poor nutrient levers can be pushed off balance. There's another lever here that we need to talk about, which is mechanical biology. And you'll see something called Wolff's Law, but basically it says, if you load it, you keep it. So when bone is loaded through things like walking and resistance training and muscle pulling and osteocytes, they register strain, and that allows formation to keep pace. So when there's unloading or immobility, the osteocytes increase the sclerostin, which turns that signaling off and shuts down bone formation. So that's why things like, say, bed rest and paralysis, even prolonged casting, or if we live on Mars one day, is going to strip away bone density very quickly. As short as 3 days, and you will start to lose bone density. So let's talk about this mechanical load. So when you load a bone, osteocytes feel this fluid shear in their canaliculi. And what happens is this signals a decrease in sclerostin. And what happens is this turns on the WNT beta carotene. And this triggers more osteoblast differentiation, which is a nice way of saying bone formation. So in short, if you load the bone, you're going to make more bone, meaning it's going to be more dense. You don't need to know all of these micropaths along the way here, other than to when we get to the bisphosphonates and other drugs, that's where they are going to start acting. So the translation in all of this is essentially loading tells osteocytes, build it here. We need bone here. So what kind of load works best? So it's not to say walk around with extra 100 pounds all day long. That's not the load we're talking about, because that's excessive wear and tear. What we're talking about are brief, high strain, high rate loads with rests in between. Something like do 20 jumping jacks. Okay, that's enough rest. That's high load, right? And the effects are site specific. So you will strengthen where you load. So like if you're a right hand dominant pickleball or tennis ball player, that right hand is going to have more bone density than the non-dominant hand. It's another way of saying use it or lose it, essentially. So let's talk about the time course in labs. So with unloading, sclerostin rises within days and formation falls first. And then resorption follows. So what we're saying is when you're on bed rest or in the space flight, 1 to 2% of hip bone mass density is lost per month. The labs will increase your serum urine calcium, the PTH will go down, your 125D and hypocalciuria will ensue, and now what? It's got to go somewhere, this calcium, so now you've set the stage for a kidney stone, essentially, because that calcium is there, it needs to be used, it's not being used for bone, your body's trying to get rid of it, and you've triggered that there. So another place where you may see this is something like in ICU sedation, limb casting, someone that's had a stroke, spinal cord injury, someone in microgravity. They all behave the same. They have a fast trabecular loss and then cortical thinning. The cortical thinning is going to be eventually what we're going to call osteopenia and then osteoporosis. So how do you counteract all this? Well, remove the insult. Early mobilization, resistive impact, training, vitamin D repletion, anti-resorptives like bisphosphonates, denosumab, things like that, if they're going to be prolonged immobilization. And then the bottom line is if unloading flips the osteocyte to high, then you can expect a fast loss and you will see hypercalciuria. And the goal is you want to prevent all this. So let's walk here through vitamin D. Everyone's vitamin D deficient. Why does this matter? Well, so it starts in the skin. The UVB light hits the 7-dehydroxycortisol cholesterol in the epidermis. And this converts it into vitamin D3, which is cholecalciferol, which you can buy over the counter at Amazon because that's the active form and it's not prescription. The inactive form, ergocalciferol, that's prescription. Why? I don't know. I didn't make the formulary. Anything that blocks the UVB, darker pigmentation, sunscreen, aging winter latitude, basically everybody north of Georgia is going to be vitamin D deficient in the wintertime. Or simply staying indoors means less cutaneous vitamin D is made. So from there, D3 heads to the liver, or a hepatic enzyme converts it into the 25-hydroxy vitamin D. That's the lab test that we care about when you're checking a vitamin D level. It's the 25-OHD. Now, this is the storage form with a long half-life. That's why we can give it like once a week and be fine at 50,000 units. And this is the reason that we are checking that 25-OHD blood test when we order it, because we want to know what someone's vitamin D status is. So that's like the fuel gauge on the tank. Now, the next stop is going to be the kidney. This is the renal 1-alpha hydroxylase. This converts that 25-OHD into 1,25-dehydroxy vitamin D. Well, that 125, or calcitrol, that is the active hormone. That's the gas actually hitting the engine. So its production is tightly regulated. So when calcium is low, PTH rises. That turns up this 1-alpha hydroxylase and increases the 125-OH vitamin D. So on the other side, you've got this FGF23 released from the osteocyte when phosphate hydroxylase breaks down the vitamin D. So in chronic kidney disease, you simply lose this functional nephron mass. So 1-alpha hydroxylase is reduced and patients can have normal or low 25D, but still be low in the 125. So our renal population, they're checking this 125 because what we're really wanting to know is, are they able to make it active? So why do we care about the active form? Well, this 125-OH boosts the intestinal absorption of calcium and phosphate. This helps the kidney resorb calcium and together with PTH supports bone remodeling and mineralization. It also feeds back on the parathyroid gland to suppress further PTH release. So a few points matter here. Clinically, we check the 25-OH, not the 125, because the 125 can be normal even in elevated deficiency. PTH is pushing that kidney to squeeze more out of a low tank. And then the risk groups include people with little sun exposure, darker skin, obesity, malabsorption, anticonvulsant therapy, the elderly, those with chronic kidney disease. All of these people are at risk for vitamin D deficiency, which eventually can lead to, how does this relate to bone? Osteomalacia in adults and rickets in children. So too much supplementation, by the way, can cause you to have hypercalcemia and hypercalciuria. And if you have one of those rare granulomatous diseases or lymphoma, macrophages can make that 125 outside the kidney. So you can see a high 125 and hypercalcemia even when 25D is not elevated. And what you want to do is treat that underlying driver. Now, what do I want you to take home from all this? When you check a vitamin D level, it's a 25 OH. Know that renal disease can affect our active form, which is the 125. That's all. Also know that there's this negative feedback loop, and that's what's driving the parathormone level, which is affecting your ability to absorb calcium, which is the bare mineral essential to lay down bone matrix and allow for resorption and healing, etc. Okay. So let's talk about PTH and the vitamin D axis now. So when serum calcium drops, the parathyroid glands release this PTH. And PTH tells the kidney to turn up that 1-alpha hydroxylase. And that makes more calcitrol. And the goal is to reabsorb more calcium and dump phosphate. So calcitrol then goes to the gut and increases the calcium and phosphate absorption, helping restore calcium. As calcium and calcitrol rise, they feed this back to the PTH, and FG23 adds extra braking and when phosphate and 125 are high. Let someone in the room. So in bone, continuous PTH exposure favors this resorption by increasing rankle, but there's this intermittent PTH, which has an anabolic property, and that's what's building the bone. Calcitrol supports mineralization of osteoid and fine-tunes the coupling by adjusting this rankle OPG axis. So while also suppressing PTH and gene transcription. So what does all this mean clinically? Well, primary hyperparathyroidism gives high calcium with high or inappropriately normal PTH. And increased bone resorption occurs. So now you have vitamin D deficiency and CKD. These cause secondary hyperparathyroid. And that's shown with the low 25D or low 125, and they're trying to drive up that PTH level. So we use intermittent PTH analogs in people with severe osteoporosis and calcitrol as an active analog, mainly in CKD to control the PTH. So that's why you may see somebody with renal disease on a calcitrol nasal spray, because that's what we're trying to do, is to maintain their bone health. All right, let's talk about here osteoarthritis. So when you think about osteoarthritis, you need to think about mechanical stress plus a failed repair in still biologically active joints. So what happens is you get this repeated load on the joint, and that activates the chondrocytes. Well, they respond by releasing cytokines, which switch on catabolic enzymes. So in plain language, the joint turns on its own scissors and starts cutting up its own matrix. And it's this process of destruction of cartilage that swells and softens. And then you get this type 1 and type 2 collagen network cleaved, cut away. And that leads to fissures and erosions down into the subchondral bone. Over time, chondrocytes become senescent, meaning old age is killing them off, and they undergo apoptosis. And so you get this anabolic repair signal that drops off, and the tissue can no longer keep up with the damage. And so bone and synovium are then reacting to this new environment. So you have exposed subchondral bone, which sees an abnormal load and responds with sclerosis and bone marrow lesions and marginal osteophytes. And what happens is the joint is attempting to stabilize itself. And so cartilage and bone debris start to irritate the synovium, and that's what's producing that low-grade synovitis that further amplifies the pain. So when you talk about osteoarthritis, cartilage loss is only half the story. So the bone and the synovium are the main pain engines. And under normal or under abnormal load, rather, that subchondral bone develops micro cracks. Well, the repair response lays down dense bone, giving us this subchondral sclerosis and osteophytes. Well, that's the joint's attempt to stabilize, but it stiffens the surface and concentrates the stress even more. So that sclerotic bone then becomes more vascularized and innervated. And new bone vessels bring nociceptive nerve fibers, which explains that activity related to localized pain and the night aches the patient may describe. If you do an MRI on this, it's going to show up as bone marrow lesions, which tend to correlate strongly with the pain flares that the patient may complain about. So at the same time, cartilage and bone debris spill into the joint space and irritate the synovium. You get macrophage predominant synovitis, and you can tell that if you aspirate the fluid. Not explosive like in rheumatoid arthritis, but a low-grade smoldering inflammation. Cytokines like IL-1 beta and TNF alpha, plus the MMPs and the ADMETs, these things will speed up cartilage breakdown and create small effusions, warmth, and joint stiffness. So clinically, you will feel a tender joint line. You may see a small effusion, and you'll notice a bony enlargement from osteophytes. On an X-ray, you may show sclerosis and osteophytes. And if management is supposed to follow the biology, then you're going to try to help the bone unload that focal stress. So how do you do that? Well, this is why we like to encourage weight loss or gait aids, canes, bracing, taping, targeted strengthening of the quadriceps and abductors. These are the things you're trying to do to essentially help this osteoarthritis of the knee. You want to help the synovium quiet that inflammation, so you could do topical NSAIDs or a short course of oral NSAIDs, or maybe an intra-articular steroid injection. If the pain is centralized, then maybe SSRIs like duloxetine can be helpful. But the last step is, of course, going to be arthroplasty. So what are the risk factors that set the stage for this? Well, you need to think about the vulnerability plus the load. So some intrinsic factors, these things are the set the joint up, and the extrinsic factors are the things that push it over the edge. So the intrinsic, you really can't do anything about. That's age, female sex, genetics. Hand and hip osteoarthritis are roughly about 50% heritable. So, you inherit it. Menopause also shifts cartilage and bone turnover, so osteoarthritis risk climbs in midlife for women. Anatomy and malalignment also, they can help load the situation against you. So if you have like a hip dysplasia, that can concentrate forces on small surfaces and lead to early osteoarthritis. If you have knee varus or knee valgus, that can override the different joints medially and laterally. So with every step of a malalignment, multiple contact stress points, you can definitely set the stage for osteoarthritis. So prior injury is another classic setup. So ACL or meniscal tears change the kinematics of how you walk. So that reduces the shock absorption. Also, intra-articular fractures can leave incongruent surfaces. So when that happens, the osteoarthritis clock has started ticking at the time of injury. Extrinsic factors are loads you can change. So obesity is a huge one. Each step sends about 3 to 6 times your body weight across the knee and risks almost a linearity in terms of BMI. So like just a 5 to 10% weight loss can reduce pain and slow progression. Repetitive occupational or sports loading, so mining, farming, kneeling, heavy lifting, elite sports, things like that. Occupational sports injuries can certainly set the stage. So what you want to do is you want to match risk to action. So ideally, you want to encourage the unloading with weight loss and gait aids and contralateral, last term I developed horrible knee pain, got a huge effusion because I had caught equina syndrome 3 years ago. And so I have like an odd gait. And so as a result, my right side is pulling my left side along. I'm like, well, where did this come from? I was minding my own business. I thought the body was trying to keep me upright and walk right. But as a result, excessive wear and tear on the compensatory joint. So you can get a compensatory injury. So it's important to look at this very holistically. Okay, so clinically, osteoarthritis pain is mechanical. It hurts with use and eases with rest. That's kind of the tell for osteoarthritis pain. Morning stiffness is brief. It should be under 30 minutes. The patient will describe this as a deep aching joint with crepitus on movement. On exam, you're going to look for bony enlargement and reduced range of motion. In the hand, you'll have classic Heberdean nodes at the DIP, and also Bouchard's at the PIP. Those are the names of the different nodes. At the knee, you might check for joint line tenderness and varus or valgus malalignment. So when you're doing your health assessment course, you can dig into joint line assessment and put the knee in varus and valgus to see if you are having pain. And at the hip, you might notice a loss of internal rotation. That's often the earliest sign. Imaging will support, it doesn't diagnose. So the classic x-ray will show you asymmetric joint spaces, narrowing and osteophytes and subchondral sclerosis and cysts. You're going to get films for any persistent pain, deformity, or to plan any injection, but not for every sore joint. And you want to separate osteoarthritis from inflammatory arthritis. So osteoarthritis has a short morning stiffness with little warmth or erythema and no big systemic symptoms. If you have stiffness that lasts over an hour or diffuse swelling or many small joints are involved or the MCPs are hot, the metacarpal phalanges, you want to think about inflammatory disease instead. So if a joint is acutely swollen or atypical, typically you want to aspirate that. Osteoarthritis fluid is seen as non-inflammatory with white cell count of less than 2,000. You always want to send any joint or any fluid aspirate, any fluid out of the body that's taken. You want to send for cell count, gram stain, and crystals to see what's in them for a joint. And the red flag is always going to be any sort of fever or acute hot effusion, any sort of night pain marked with redness, weight loss, recent surgery, or immunosuppression. Those are the things that are pointing towards what might be a septic arthritis or a malignancy. So that might need urgent workup. Okay, another kind of arthropathy here is gout caused by monosodium urate crystals. This occurs in the synovial fluid, and you will see needle-shaped crystals with strong negative birefrigerants. And so these appear as yellow when they're parallel to the compensator and blue when they are perpendicular. And so gout classically starts at the first metatarsophalangeal joint of the great toe. So it also can involve the midfoot, the ankle, or the knee. And in chronic disease, you may see tophy or erosive changes. Mechanistically, elevated serum uric acid levels and urate crystal depositions may be seen, which activate that inflammasome and the interleukin-1 beta-driven inflammation. Another kind of crystal arthritis, if you will, is this calcium phosphorate deposition disease. I had this one too, on my thumb. Woke up in the middle of the night with the most horrible pain in the world, didn't know what the heck it was, and my thumb was swelled up. I'm like, this is ridiculous. I can't even button a shirt. I went to make an appointment. I have a hand guy on retainer. I went to see him, and he does the MRI. They leave me alone in the MRI to get dressed on my own, but my thumb is out to here. Took me 30 minutes to unbutton my shirt to put the stupid gown on, because of course when you go in the MRI, it's my thumb. Nope, take everything off and put on this gown. Like, it's just my thumb, but suffice it to say, I discovered that I had this calcium phosphorate deposition. Nothing to do, steroid taper, it went away on its own. But I'm like, okay, note to self, I don't know what the heck that was. Horrible. Anyway, these rhomboid crystals with weak positive bifringence, they look blue when they're parallel to the compensator. This condition tends to favor the knee or the wrist or the metacarpal phalangeal joint, as it did in me, and it can also be in the hip. It often flares in places where there's already degenerative osteoarthritis. Don't have that. So at any rate, this thing can flare up. Also, if you have an osteoarthritic knee that keeps acutely swelling, this should make someone think about a calcium phosphorate deposition. So you can do that by aspiration and MRI and have a definitive diagnosis that way. Now, some common triggers to all of this, to gout especially, alcohol, especially beer, red meat, shellfish, thiazide and loop diuretics, dehydration, surgery, and acute illness. They used to call this the rich man's diet. For obvious reasons, based on the diet that goes with it. And then for calcium phosphorate deposition, the risk factors or the triggers for that are things like trauma, surgery, and acute illness. With recurrent attacks, now you need to screen them for hereditary hemochromatosis. So you know how you hate the hematology lecture, but I want to make this final cumulative? Maybe I'll give you a scenario that includes recurrent calcium phosphate deposition and hemochromatosis. So now I can cover two systems with one question. See how I can do that? So anytime you see an overlap of the inflammatory cascade from one system, I can cover a lot of territory by intersystem, by doing it as a multi-system question. So that's what I mean when I told you, by the way, the final is cumulative. So the rule is this: synovial fluid is the truth. If the joint is hot and swollen, you want to aspirate it and exclude septic arthritis, and then identify the crystals. Okay. All right, let's talk about bone in the cartilage here. So if we think of the joint as a one osteochondral unit, cartilage and the subchondral bone are talking to each other all day long. And so the subchondral bone is sick, and the cartilage is going to follow. And when the cartilage fails, the load on the bone gets worse. So you're going to do an MRI or looking for a bone marrow lesion to show up as patches of edema and microfracture and fibrosis in the subchondral bone. These are the areas that are highly innervated and highly vascular. So these will correlate with pain much better than just cartilage thinning on an X-ray. Pain in osteoarthritis largely lives in the bone. And so this is how bone injuries affect the cartilage. So what happens is you get these micro cracks in the subchondral plate, and they trigger remodeling, and they make the plate stiffer. And so this stiff plate transfers that load abnormally, causing shearing and fissuring, and then in the overlying cartilage. So now new blood vessels then have to push up across that tide mark, bringing nerve fibers and inflammatory cells into this territory that was supposed to be quiet. And now you've got this chemical crosstalk going on between the interleukin beta-1 and the tumor necrosing factor and prostaglandin, and this matrix of metal proteinases and such, and they're all like firing essentially. So what you get is this inflammatory situation, which is what characterizes the osteoarthritis. So again, offloading, And weight loss, these are the things that are going to help reduce pain because it's all symptom support until you eventually replace the joint. Now, osteoporosis here is not just thin bone. It's uncoupled remodeling. So you have osteoclasts, which is the bone resorbing cells, right? These are working faster and longer than the osteoblasts, which are the bone building cells. So every remodeling cycle leaves the skeleton a little weaker. So why the balance tips? Well, with aging and estrogen loss, osteoblast lineage cells make more receptor activator of the nuclear factor of this rankle and less osteoprotegerin, which is this OPG. And what happens is rankle promotes osteoclast formation and survival, whereas OPG is the decoy receptor that normally soaks up the rankle. Well, the glucocorticoids and this chronic inflammatory cytokine cascade of interleukin and TNF, this pushes that same axis towards resorption. So you have this low calcium vitamin D trigger secondary to hyperparathyroid, increasing this parathormone, which upregulates this 1-alpha hydroxylase, and that raises your vitamin D level. So eventually, what fails here? You're hearing the same method of failure over and over because this is how the body fails, and what we're getting at are the different ways that triggers this failure cascade. So what actually fails here is this internal spongy bone. You get this trabecular perforation, struts the brake is no longer able to connect. So this causes a big drop in strength, specifically where? The spine, the hip, the wrist. The outer shell you see is that cortical thinning and increased porosity. So this is what you're seeing as like porous bones or low bone density. That's what makes up the hip and long bone fractures. This is also very hard to sometimes see if they're very osteopenic on a plain x-ray. So if you're concerned, you might have to do a CT scan on someone with severe osteoporosis to actually find the fracture. Okay. So there are some anti-resorptive therapies that we can offer that target this rankle OPG axis here. So the most common are the bisphosphonates, such as alendronate and his friends. And so what this does is it's inducing osteoclast death. And that's kind of a first line. And this, once the risk is lowered and stabled, then we can consider a drug holiday. Denosumab, which is a monoclonal antibody, goes against rankle, and that's pretty potent. But if you stop it abruptly, you will see bone loss rebound. So you have to follow it with a bisphosphonate. Now, there are some anabolic therapies that can rebuild the structure and some intermittent parathormones that can be given. It's beyond our level at this point. This is definitely going to be in the domain of metabolic bone and rheumatology. But suffice it to say, there are some options, but it's all going to be trade-off, essentially. Now, let's talk about osteoporosis risk factors here. You can see that there are some non-modifiable ones on the left column and the modifiable ones in the right column there. You can't do anything about your age, your sex, your ethnicity, your family history, and how fragile you are to begin with, but we can certainly reduce the medications that can be insulting and enhance the nutrition, mobilize you, reduce the smoking, and try to taper any meds that can be removed. How do we diagnose these things? These are some diagnostic tests. The DEXA scan, basically this is a score that's normalized. You're going to get a T-score, and if you have it less than 2.5, that's the classification for osteoporosis. There are some common pitfalls here. So spine osteophytes, aortic calcifications, and vertebral fractures can falsely elevate the spine bone density, and so you want to lean more on the hip. Essentially, you don't want to do a DEXA of just one part of the body. You want to do a full DEXA scan where it looks at wrist, hip, lower back, and then you can take a composite average of all of those scores. But of course, where the low bone density is, we assume that that's where is going to be the fracture. So let's talk about how you heal from a bone fracture. So the big picture here is bone heals by endochondral ossification, basically replaying development. So you get a hematoma, then cartilage scaffolds, then bone, and then over time the bone reshapes along the line of stress. And so stage one is that hematoma. So in the first hours to days, and this fracture tears vessels, and then a clot forms in a hypoxic acidic pocket. And then platelets and macrophages release, transforming that growth factor, beta, TGF, and platelet-derived growth factor, PDGF, and vascular endothelial growth factor, VEGF, interleukin-1, interleukin-6, tumor necrosing factor. These are the things that signal and recruit the mesenchymal stem cells so that new blood vessels can form. And clinically, this is a pain and swelling situation. This is early stability of this matters because too much motion in an early fracture causes continual re-tearing, and vessels can enlarge that hematoma instead of moving you forward. So that's why early stabilization is really important at the initial point of fracture. Stage two, in the inflammatory granulation phase, this happens over days to the first 1 to 2 weeks. The clot gets replaced by granulation tissue, fibroblasts and new capillaries form. That mesenchymal stem cell starts to differentiate in a low oxygen and more motion, and they become chondroblasts, and they lay the cartilage in a better oxygenated and more stable locale, and then they become osteoblasts that eventually lay bone. This stage decides the mechanical path. The more micro motion gives a classic secondary healing with a callus. Rigid fixation pushes towards primary bone healing with little callus. Stage three, this is the reparative phase. So roughly this takes weeks to about 6 weeks. And here you'll see a soft callus of fibrocartilage that bridges the gap. And then gradually this will mineralize into a hard callus through endochondral ossification. You might get some hypertrophic chondrocytes here. You'll get some calcified cartilage, and then this is weaving bone. On x-ray, you'll start to see denser callus, and the patient's pain improves, and the limb is going to be able to eventually tolerate more load. And there's relative stability here. Casts and intramedullary nails are holding this together sometimes, and then you might see plates that allowed for controlled strain. You want to optimize the callus, and then absolute compression and plating gives this primary healing. The final stage is stage 4. This is remodeling, and this can take months to years. This is where woven bone is replaced by organized lamellar bone. Cutting cones restore the medullary canal and the cortical architecture, and then the shape of the bone realigns with the stress pattern. So how you use it, the bone will assume that shape. Children remodel faster than adults. And metaphyseal regions, they heal faster than diphyseal region, than the shaft, essentially. And when you deal with fractures in children, it's very important that you preserve that growth plate. Otherwise, you may stunt the growth of the limb. Okay. So we have a problem of non-union. So why osteoporotic fractures? Why do you think they heal poorly? Well, they heal poorly because osteoporotic bone has less osteoblasts. It's got a thinner trabecula and impaired angiogenesis. So the callus is small and mineralizing is slow. So you need to think of this in 4 buckets. The first is the mechanical bucket. Too much motion at the fracture site and a large gap and inadequate fixation or hardware failure. That's all driving this hypertrophic non-union. You see lots of callus, but it never bridges. The remedy here is to improve stability and add compression. So this may need internal fixation or a rigid cast. Secondary, you got poor biology here. So poor perfusion of soft tissue loss sets the stage for infection or necrotic bone ends to an atrophic non-union. So you get little or no callus at all. So here they may need surgical debridement. The third is this host factor. So if they're poorly physiologically predisposed, so this is your smoker, you're diabetic, you're malnourished, you're anemic, you're one with low vitamin D, the one with advanced age, all of that essentially is another reason for non-union. So the best thing you can do is optimize the lifestyle, supplement the vitamin D, the nutrition, and the protein. And the fourth is if they're on some sort of medication that's inhibiting this, say glucocorticoids suppressing the osteoblastic activity and enhancing osteocyte survival. They could be on NSAIDs, which also in high doses over long duration can delay healing. So the risk is the dose and time dependent. It's not to say they can't have an Advil, but you don't want to be on long-term Advil while you're trying to heal a bone fracture. So the remedy is to reduce the steroids and get the NSAIDs down as low as possible and consider some sort of adjunctive pain control measures as well. So you kind of want to support healing as much as you can, especially in the osteoporotic patient. Now, in osteoarthritis management, these principles we're just reviewing: weight loss, you want to reduce the strain, and you want to reduce NSAIDs as much as possible, and you want to encourage bracing, assist devices, and collateral strengthening. So this is the medication classes for osteoporosis. I don't need you to know them per se. I'm not going to ask you which drug for which condition, but in general, what is the mechanism of action, and where are we pathophysiologically interacting to enhance healing or stifle, or stifle degradation? Okay, so peak bone mass is mostly decided early in life. About 90% of peak bone mass is set by age 18 to 20, and roughly a quarter of it is gained in the first 2 years of pubertal growth. So what kids do in that window locks in a big part of their lifelong fracture risk. So the drivers of bone accrual are simple: food, load, and hormones. On the food side, children and adolescents need about 1,000 to 1,300 milligrams of calcium per day, ideally from diet. Plus, they need about 600 to 1,000 international units of vitamin D per day. And they need adequate protein. On the loading side, bones need impact. So high impact weight bearing activities, jumping, cutting sports like basketball, football, things like that, at least 3 days a week, with the goal of 60 minutes of daily activity, and that will send the build bone signal. Track is good for this as well. On the hormone side, growth hormone and insulin-like growth factor, along with the sex steroids, all of these ramp up osteoblastic activity during puberty and amplify the bone formation. So several things blunt this peak bone mass: low energy availability or relative energy deficiency in sport. That's abbreviated REDS, relative energy deficiency in sport. Amenorrhea, malabsorption, smoking, vaping, chronic illness, immobilization, glucocorticoids, all of this will slow bone growth, especially at this high time of development. So you want to avoid those things. In juvenile idiopathic arthritis, JIA, chronic inflammation with cytokines such as tumor necrosing factor and interleukin 1 and 6, these increase receptor activator nuclear factors. So the problem is someone with JIA is going to be likely to have a lower bone density later on because of this predisposing condition. So we want to treat inflammation early in this disease with disease-modifying anti-rheumatic drugs known as DMARDs when you see that classification, and sometimes biologics to minimize steroid exposure. And you want to encourage pain-tolerant weight-bearing and resistance activities. So I told you early on, the best thing we have to prevent decline is resistance activities, weightlifting. Everyone start lifting weights, essentially. And also you want to make sure that they're getting good calcium and vitamin D and that the levels are optimized. Let's talk about pregnancy and postpartum. So during pregnancy, the body's goal is to absorb more calcium, not strip it from the bone. So the placenta and the maternal kidney both increase the activity of the enzyme 1-alpha hydroxylase, which raises that level of calcitrol, the active form of vitamin D. That extra calcitrol lets the gut absorb roughly 2 to 3 times more calcium to meet the fetal needs. Maternalized ionized calcium stays normal, even though total calcium on the lab report may look a bit low because of hemodilution. One important thing to keep in mind is the ALK phos rises in pregnancy because of the placental isoenzyme. Don't chase that as a sign of bone disease. That is a popular boards question, by the way. I've seen it 3 times as to ALK phos in pregnancy because of the placental isoenzyme. Don't chase it as a sign of bone disease. In lactation, the case is different now. So now the system uses short-term bone withdrawal to supply calcium in that milk. That suckling stimulates parathyroid hormone-related peptide from the breast, and estrogen levels are low. Together, this tilts that receptor activating nuclear factor against the OPG towards osteoclastic activity. So what do you think the condition is that can develop here? Well, in 2 to 6% of trabecular loss at the spine and hip with weaning and the return of menses, the bone mass will usually rebuild and regain. So you can have a transient osteoporosis in pregnancy. And that is abbreviated TOP, by the way, transient osteoporosis of pregnancy. This typically appears late in the 3rd trimester and early in the postpartum period as a deep hip pain with an antalgic gait. If you do an MRI, you'll see that there is a bone marrow edema without collapse, while plain x-rays can still look normal. The main concern is an atraumatic femoral neck or vertebral fracture. This is a pathological fracture that can happen. And management is generally conservative, done with activity modification, crutches, pain control, increase the calcium and vitamin D, and planning delivery in a way that minimizes fracture risk. This is also why some women may develop a pelvic fracture in delivery because there's a lower bone density there. So if there's a cephalopelvic disproportion, there's a good chance that that can occur. We generally avoid bisphosphonates in pregnancy. There's a more serious red flag you should know about. It's called pregnancy and lactation associated osteoporosis. Pregnancy and lactation associated osteoporosis, or PLO. This is where you see severe back and hip pain, height loss, or actual fractures late in pregnancy or early postpartum. Those patients need an evaluation after delivery with a full DEXA scan and also lab work for secondary causes. If the fracture burden is high, then anti-resorptive and anabolic therapy may be started after breastfeeding ends. But definitely you're going to be in the plan of metabolic bone rheumatology, and OB are going to be working together on this. So in the geriatric population, we talked about sarcopenia. We also talked about it in the renal lecture. So think of muscle and bone as one organ system. That's why they call it the musculoskeletal system. The muscle bone unit, with aging, we move less. So there's less mechanical loading on the bone. That decrease in load increases sclerestin. And this is what turns down this WNT signaling, which lowers the osteoblastic activity and bone formation. So at the same time, you may see chronic low-grade inflammation, as you'll see elevated interleukin-6 and TNF. This raises that rankle and speeds up bone resorption. So the net result is bone loss plus muscle loss, which we experience clinically as frailty. Fracture risk explodes in frailty because it's not just low bone mineral density, it falls plus weak muscles. So the loss of strength in the quadricep and the hip abductor and the slow gait speed and the poor balance all predict hip fracture better than lean muscle mass alone. So when you add sarcopenic obesity, that is fat infiltrating the muscle, you get even worse picture and worse power and more insulin resistance. So the patient cannot catch themselves when they trip. So this is a multi-system involvement of inflammation and slow degradation over time. So what you do here is you want to prescribe physical therapy with resistance training 2 to 3 times a week, focusing on hip abductors, quadriceps, and that posterior chain. I'm basically sending everyone over 50 to Pilates as oftentimes as I can get them into Pilates, because this is all about core, hip, pelvic, abductor, and posterior chain. Because as you get older, it's all about maintaining strength and flexibility to keep you from going over. Okay, let's do some cases and we'll wrap this up. Good on you for your stamina. Better on me for mine. All right, 62-year-old woman here with a BMI of 33. She has a varus knee, that is medial compartment overload. The x-ray shows a joint space narrowing and osteophytes and subchondral sclerosis. You see classic knee osteoarthritis pathway in one line. You see some focal mechanical overload. There's some chondrocyte stress. There's cartilage loss. There's subchondral bone responds with sclerosis and osteophytes and ingrowing nociceptive fibers. There's some low-grade synovitis here, which is causing our pain. So the main pain generator is that synovitis. The cartilage loss itself is painless, but pain is coming from the bone marrow lesions and the synovium and the meniscal extrusion tear and this periarticular muscle. So management for this person is going to be weight loss. Even 5 to 10% can reduce that knee force. And we're going to do things like biomechanics, PT for quad and hip abductor strengthening and gait training, so she can do away with that compensatory gait that's possibly putting her in that varus knee position. And sometimes they may need like a lateral wedge insole in the shoe if those varus symptoms persist. And medial unloader brace to shift the load laterally, and sometimes a cane if needed. And the goal here is we want to quiet that synovitis. So topical NSAIDs, maybe some oral or a shirt torn, maybe some intra-articular steroid injection. And if it's central, then duloxetine. And then when we get to activity, we want to really promote the resistance activity. And, we're trying to manage the decline, essentially. This is another case here of a 72-year-old woman with a ground level fall and intratrochanteric hip fracture. Her 25-OH vitamin D level is 18, which means she is severely deficient. And by definition, this is a fragility fracture. So we're going to treat her for osteoporosis regardless of what the DEXA shows. So we treat the fracture and we start an anti-resorptive or anabolic depending on risk. We want to definitely replete the vitamin D here, and she will get a DEXA follow-up at the end of healing. All right. So, yeah, Aisha.
Um, If you have time just to talk about NSAIDs, the way I understood it is that it's a problem to take NSAIDs after a fracture because it's problematic for healing.
Time and
But
dose,
then,
time and dose dependent. So it's okay acutely, but when we get to like that week 2 phase, you really want to come off that when the bone matrix is really being laid down. So you want to avoid it at that point, or at least be on the least amount of most effective medication. Acutely,
Mhm.
it's fine.
Okay, and what is it problematic in osteoarthritis?
Well, yeah, because essentially it's going to be a downstream effect. We don't want to put anybody on long-term NSAIDs if we can avoid it, right? Because, we've got all those secondary effects to contend with. We're not curing the arthritis with it, right? It's not reversing the disease process. We do want to mitigate the inflammation. So it's okay in short terms. You may want to supplement that with acetaminophen. You may want to supplement it with topicals, ice. Sometimes an intra-articular injection is necessary, but you're going to have to do a risk-benefit analysis of long-term NSAID versus the secondary adverse effects. And at some point, you're going to have a conversation about how bad is this and does it warrant arthroscopy or a joint replacement in lieu of leaving you on years-long anti-inflammatory, essentially.
Thank you.
Yeah. So let's finish this up here. So the skin pattern, the action will determine the action. So you want to start in the skin with pattern recognition. And you confirm this with bedside tests when it changes the management. So in other words, we don't want to do a test if we're not going to change the management. Okay. And so that's what we want to keep in mind. And you want to keep in mind these immune drivers, this Th2 barrier and failure. That's what's triggering this eczema cascade that follows. And this keratinocyte hyperproliferation is the thing that you are seeing in psoriasis. Okay, so this is a T cell cytotoxicity drug reaction. That's what drives that drug reaction is its T cell cytotoxicity, and that will lead to apoptosis storm, which is what you're seeing when you're talking about things like Stevens-Johnson syndrome and TEN. And the red flag trigger in the skin is that urgent triage for necrotizing fasciitis, purpura fulminans, and that sheathing of the skin with mucous membrane involvement. With respect to bone, what I want you to take home from this is that the load plus the hormones is what's leading to that remodeling set by the mechanistic action. So essentially, the load and that endocrine axis is what determines how that bone matrix is going to be laid down and how you're going to heal and how predisposed you really are. And you want to take this lifespan lens to everything you do. Consider the age and stage that the patient is in. Know that peak bone density is forming in the first 2 years of puberty, and it's very much driven by nutrition and weight-bearing status. You need to not forget that pregnancy and lactation can affect calcium economy, so transient losses do recover post weaning, so you don't jump on those too actively. Keep in mind that in geriatric, the sarcopenia osteoporosis is how we are defining frailty. So muscle first, and then protein needs to be encouraged with resistance training and supportive exercises. And ideally, you want to prevent all of this. So what I want you to take home from all of this is you should not memorize as much as you should look for patterns. Okay, there's not going to be an alphabet soup on your final per se. And in the clinical setting, no one is asking you to be responsible for the chemical soup. I'm sorry, the alphabet soup. What we're asking you to be responsible for is to know how things are connected so that when you're prescribing, you're able to connect mechanism of action to pathophysiology. So you can explain to the patient what's going on, why we're doing the things we're doing, why do things take so long, why is it 6 to 8 weeks for bone to heal, why did I have this reaction in, say, 12 to 72 hours instead of right away, or why in 2 to 8 weeks. That's kind of the reason you're doing this, because a lot of what you'll be doing is providing anticipatory guidance, and so that's what you're really getting at. You guys have any questions? I'll be happy to take them. If not, this will be put up